Good morning, everyone. We will be starting in 5 minutes. Till then, please keep your mic switched off. Thank you.
No, we are. Oh, I see. Problem is this color. Okay. Ah, to take a minute. Blue sheet will end. बहुत सारी पड़ेगी, including the disposable bag. इसके ऊपर ना फिर contrast होगा. कोई मैं देखा मैंने ध्यान ही नहीं.
Hello, a very good morning to all of you. I am Ananya Korzekar, the Academy Team National Assist at GSN. Our event for today is Sharpen Your Knot, a national level suturing workshop brought to you by the Global Surg Network in association with Gurukkul of Surgical Disciplines and the American College of Surgeons India chapter. We have with us today the founder and president of GSN, Akatya Vidushi, the Academy Team Director, Dr. Udit Kathuria, and the Academy Team National Assist, Shamalan Murugaya. I'll now hand it over to Akatya for the introduction of GSN.
Thank you, Ananya. The Global Surg Network is a student-led surgical society which aims to bridge the reach of global surgery through surgical education and training. Over to you, Ananya.
Thank you, Akatya. Before we begin, a small introduction about today's workshop. As you all know, suturing lies at the heart of surgery. The result of any surgery is as much linked to the suturing as it is to the actual surgical process. And hence, as future surgeons, it is absolutely essential that we master the skill. And who better to guide us than Sir himself? And now it is my utmost privilege to introduce our esteemed guest for today, Professor Chintamani, sir. Sir has completed his MS, FRCS from England, Edinburgh, Glasgow, and Ireland, FACS, FICS in Surgical Oncology, FIMSA, as well as MAMSE from the American College of Surgeons. Currently, Sir is the President and Governor of the American College of Surgeons India chapter, an international surgical advisor at the Royal College of Surgeons of Edinburgh, UK, the President of the Asian Society of Mastology, a member of the Academy of Master Surgeon Educators, and a Fellow of the Royal Society of Medicine, UK. Previously, Sir has served as the Editor-in-Chief of the Indian Journal of Surgery, as the President of the Association of Surgeons of India, as well as the President of the Association of Breast Surgeons of India. Sir is also the Joint Editor of the Indian Journal of Surgical Oncology and the former Head of Department of Surgery at VMMC Safdarjung Hospital. It is an absolute honor to have you with us today, sir. Finally, before we begin, a few housekeeping rules. I request all the participants to keep their mics turned off during the entire event and their cameras turned on. If you have any doubts or queries, feel free to put that in the chat box and we will address them later. Finally, please maintain decorum and let's have a productive session ahead. Now, I request Sir to kindly take over from here so we can begin with today's workshop. Thank you.
Thank you. Very good morning to all of you. Now, first of all, it's truly a pleasure. We keep doing these basic skill workshops on a regular basis for the benefit of students, postgraduates, as well as undergraduates. And truly a pleasure to be doing it yet again. Now, I'll just reinforce a couple of housekeeping points. One is don't switch on your audio. Don't create any nuisance, please. Little distractors, you'll get to do everything, and I hope you've been able to arrange the material as we had passed on, as Dr. Sukriti, my registrar, who will be assisting me today in the workshop, and Dr. Vivek Srivastava from J&J, who is very much here. I don't know if we can show his face by turning the camera towards him. And also Mr. Vinay, they are going to assist me, and that
it's there, Vinay, you can just show it to me.
Yes. So that's Dr. Vivek, who is responsible for all that happens in the J&J. They have provided us all the material, the simulators, although I would still like to show you on the kind of simulators you must have created. And every time we have a new invention from the students. So we'll be looking forward to that. And to let you know, we are 1500 plus registration already, and the Gurukkul groups are all full. We are not able to allow them any access anymore. They are watching on the YouTube. If there are any questions, you're welcome to type in the chat box and also ask them when I say. So you can unmute at that point. There'll always be a time when you can show what you've done in the gallery view, and we'll control that. And for, as I mentioned, the regular assistance for all procedures that happen will be done by my registrar, Dr. Sukriti, who will be in touch with all of you. What are we going to do today? Well, we already announced it, and it just keeps getting bigger and bigger each time. That's Dr. Sukriti, and we have instruments first, then we'll have the little introduction to instruments, necessary for all students to know. Then we move on to the suturing and importantly the knotting, where you are all in knots. That's the most important part of the workshop. Once you learned it, we'll teach you how to actually put continuous, interrupted, and all those kind of sutures that you will need in your practice. Beyond that, we'll be, if you're doing well and if you want it, then we'll be doing the abdominal incision and closure, followed by bowel anastomosis if you still do well. And if you're doing good and I'm happy, then you do vascular anastomosis. And if you make me happier, you'll do the tendons. So there's a lot lying there in store for you. And therefore, it's very, very important to pay attention. Now, just one more point before I start. We are a little delayed, not on account of anything that we didn't start at 10:30. We need to have everything in order in place for all of you to be able to follow it. And we will be on the roll. Now, I would be very happy to see somebody in that attire. But if you're at your home, I can understand this is COVID time, so it is accepted. I think we are good to go. So let's start with the basic theater etiquettes, which we teach almost routinely. Now, one is you should be, of course, gowned and gloved. You should be having the right kind of a mask on your face. This is N95, as you all know, and it is mandatory to have it. We must have our gloves on. How to put them on is what I'm going to show you in a hurry because we don't have time for it. For all those who want to see it, you can click that one down. So we will try to show you the open method of gloving, and then you can see the closed method of gloving if you have time. And we'll start talking about universal precautions. So keep your notepad handy so that you can use it whenever you have any comment or something to note. Besides this, you will be then introduced to the instruments and we will be starting. Give me a moment. We are fixing the camera of the J&J, which should be taking it to all corners of the world. So feel good about it. That's what is more important. Enjoy your day and importantly learn in the process. So it's fun and learn. That's what we do at the Gurukkul of Surgical Education. That's our purpose. And I'm sure a lot of you, we have nearly 10,000 plus members of the group. They'll all be postgraduates, undergraduates, also faculty. They'll all would be joining anyway. So we have a large group, but I'm focusing on undergraduates in this course so that they don't miss out on some skills which postgraduates might think they've already got. If they've got it, it's good to reinforce because you'll be surprised that many things you can still learn and build on. So let's start. These are the gloves that you see these days, which are in the theater. These you've already seen. So whichever glove you wear, usually wear double gloves. The purpose is to be putting on 2 gloves for universal precautions. Universal precautions are precautions that you undertake assuming that every patient is a potential HIV case or a hepatitis case unless proven otherwise. I'm repeating because this question repeatedly is asked and people give all sorts of very answers. The answer is whatever is universal is something that is applicable practically all the time. The universal precautions are precautions that you undertake assuming that every patient is contaminated or infected unless proven otherwise. So that automatically rules out where you are not going to do what. You've got to do it all the time. That's why it's called universal. And they now include, most of the students end up answering putting on a headgear, putting on a mask, double gloves, shoes, apron. These are ways of assuming it. They are not by themselves universal precautions. So please understand the meaning of universal precautions. It's very important. Well, I'll just demonstrate to you how do we peel off the cover. Very easy to do. I've already washed my hands and usually I'll keep my hands up and elbow down. This will be off. So just demonstrating. And after you've done your washing, and this, if you're interested, watch my YouTube videos on this. Once you've done that, you're ready to put on a glove. Now, how do you put on a glove? Usually, it will be lying like this for you, or you will open it up, and we are going to do the open method, which is what you all practice. Now, if you guys leave me a little space, I can take my mask off so that the audio is fine, right? Now, I was demonstrating the putting on the gloves. This is the left, this is the right. And for a right-handed individual, it's usually the left hand that he'll wear first. That's what I do. And there's no one way of doing it. This is one correct way of doing it. There are so many ways of doing it. Now, this is the inner side of the glove, and that's the outer side of the glove. If you can zoom here. Now, inner side, outer side, which would mean, can you zoom here? Yes, so inner side and outer side. So I can, with my bare hands, I can always go into the, touch the inner side, but I won't touch the outer side. Now what I do is, I slip in and I leave it where I am. Similarly, on the other side, for the other hand, I'll hold again the inner side. And there's a ring to help you here, which you can, little bit of pulling is all that you need to do. And you can understand that the inner side is, I've got a glove on, so I'm comfortable holding any side with a gloved hand, not with a bare hand. That's what I was trying to show you. Now, if you do it with your normal gloves, it's going to be easy. See, if I was to do it on one side. Now, since I'm going to wear it in the right hand, I'll hold. This was just to demonstrate to those who are left-handers. Now, the other method is very simple. I can put in my fingers because I'm gloved, so there is no issue. And I can just pull it up and I'm done. Now I can hold on to the ring. And under this would come the sleeve of my gown. So I'm ready to go. Now all of you can put on your gloves if you got them with you. I'm giving you half a minute. And then once you got the gloves on, if you don't have the gloves, I don't think that's such a tight scenario today. You can always get gloves these days, and a lot of markets have now opened up, so that will be possible. Now moving on to the first exercise, that's to touch the instruments, learn about them. Now, can you zoom as soon as I show this? That's a Bart Parker handle. Don't call it knife or a scalpel. That would be a wrong answer. It's a handle. It doesn't have the blade. And long before these detachable ones, it used to be a fixed assembly, which you see in disposable ones even today. But the problem with the fixed assembly is once you autoclave, the sharp instruments will become blunt and you'll have to throw them away. That is not going to be a good idea. Now, these serrations, wherever you see serrations, that would indicate the place where you should hold it. Whichever instrument has serrations, that's the place to hold it. Now, there is a slot here, and this is for the blade to sit, right? I think both cameras are showing the same thing. This too. Okay, so now we have the exercise of putting the blade on. Now you know these days it comes as a disposable pack. The purpose of having detachable handle is very simple. You can autoclave this repeatedly. So it can be used, reused, reused, but this can be used only once. So that is the purpose of having a detachable blade. Now, if you want to see what is inside, you can open up. But before that, earlier the wrapper used to open on both the sides. You would palpate for which side is the sharp end. You don't want to touch the sharp end. This is part of the universal precautions. Don't ever handle, two hands should not handle sharps. They need to be exchanged in a kidney tray or in a box or something. Okay. So now this side, the wrapper opens. It's very simple. You open it up, and what is showing is the rear side of the blade. Now the rear side of the blade will be presenting to you. And now please don't use your hand. You can take it out with an instrument. Like in this case, I've used an artery forceps, and I'm not still comfortable and I'm not aligned properly. So I can go the other way around. I can circulate in whichever way I want. Don't use your hands. Don't think these injuries are rare. Needle stick injuries, sharp injuries are commoner than you think. And you slide it in, it sits. And that's the first exercise, which you will all do. Now, the second exercise is to how to get you off. I'm showing you both so that you can practice both. Hold the rear end, give it a gentle push, and don't let it fall away. Now I'll repeat. So loading it, the first exercise. Very easy, very, very easy. Now, all of you have got the blades, so you can, with a click, it will settle, right? I hope it is visible. One of you should be unmuted and keep responding.
Yes, sir, it is visible.
Thank you. Now, if you have to take it off, you hold the rear end and give it a gentle push and leave it there. And where do you throw it? Say some safe area. You shouldn't have it flying all over the place, which is a mistake. Now, the reason why you should learn the correct way of doing things is, if you don't do the correct way, people throw you out of the OT. Reason is simple. You're harmful, dangerous to others. That's it. Not besides being dangerous to the patient. So that's simple. Now, I'll give you that time. Don't worry. You can practice it. Now, I'm using a skin pad. You would have any pad. Anything is as good. Now, how do you hold the scalpel? Don't call it a knife. Knife is used by criminals. We call it scalpel in surgery. And it has serrations, as I mentioned, and that's where you hold it. There are two main grips. One is the classical or the conventional grip. It's also called the palm grip because you find it sitting in your palm. Between the middle finger and the thumb, and index finger gets on top of the belly. What is the belly of a knife? The bulge. You know what is belly. And the sharpest part of the blade is the belly, not the tip. So don't give that answer wrongly. And it's not the tip, the belly. Now, if I have to make an incision, remember, don't give an incision, you always make it. There's nothing to give in an incision. It's making of an incision. What do? I'll use my left hand to spread the skin apart. I'll just adjust it, don't worry, for the camera. And I'll keep it at an angle of 45. And from point A to point B, as I advance, I'll keep on going smoothly, stretching the skin. When I reach the other side, I will give it a slight palmar flexion so that my incision doesn't tail up. Right? So that's how you make an incision. You can see the incision is neat. Now remember, scalpel cuts from a point to your left to a point to your right, and or a point away from you to a point towards you. That's incision. You can hardly see that incision. And any incision is the signature of a surgeon, how well you made it, and finally how well you sutured it. So that's all the patient sees. He cannot see what you did to the organ inside. So all he is looking at is the incision that has been sutured. We call an incision and a scar the signature of a surgeon. Now that's the incision. So you make an incision from a left to a right point, or a point away from you to a point towards you. Scissors is just the opposite. Easy to remember. Left to right. Far to near. That's scalpel. Scissors is right to left. Near to far. It's just the opposite. Easy to remember. Now, that's one grip. So that's the palm grip or the conventional grip. Sometimes you have to make a complicated incision, or you have to use the scalpel for a different purpose, like raising a flap or making an incision which is complicated. It's a good idea to mark your incision. I always mark my incision except in the abdomen, even in abdomen. The reason is, if you mark your incision, you also know the points where you're going to suture. So it's a good idea to mark. Okay. Now, if I have to use it like an artist, my grip will change into a paintbrush grip. What is a paintbrush grip? I'm holding it exactly the same way as I hold a paintbrush. And what do I use? I'm not using the belly now. What will I use? I will use the space in between the tip and the belly. Now, I'm lifting up the edge, and you can see that. I'm trying to raise a flap. How would I raise a flap? I'm using which part? See, I'm using the part between the tip and the belly. So you would know what is the purpose. See how beautifully the flap comes out. Now, if you're asked a question between the scissors and blade, which is better and more useful, most of you will answer scissors. But the answer is scalpel, because anything that has got two blades will always crush before it cuts. And whenever you crush, you kill the tissue. The amount of tissue crushed or burnt or tied is responsible for postoperative action. Therefore, always remember this. But there are places where you cannot use the scalpel. You cannot go to the depth and use the scalpel. You can't go along the cavity and use the scalpel, because it has only one straight approach. There are other types of scalpels also. In fact, you call diathermy or cautery as hot knife, because it's also cutting. So hot knife would be useful to prevent, it'll be good to make a sharp cut. But importantly, there are places where scissors would be used. Since I mentioned, so this is the second grip, which is the palm grip and the paintbrush grip. The third one is a Bisturi grip, which we don't use anymore. So you don't need to really remember, because that would mean amputation, where you would cut like a butcher. That knife is no longer existing. Always remember to put it in a kidney tray. At your home, please get a bowl to do it. Don't be clumsy. I'll ask you to show your table in the middle of the workshop. And we do mark for that. And we have special certificates from the Gurukkul and American College of Surgeons, for especially those who are going to become scholars for the college. We select scholars every year, 15 scholars every year, you know that. And that is based on the overall performance for the whole year. So do show your knots well, do show your sutures well, but more importantly, show your etiquettes well. So keep focused. You may be one of them. So we'll choose 15 today, and you'll be marked for whatever you do. That will be done by Dr. Sukriti as to how you did your knotting, how you sutured, how you kept your instruments, and try to keep a kidney tray. It's not impossible to find in your house. Take up any bowl, but keep it there. So don't throw sharps anywhere, and I've left it here. Now, I've already talked about the scalpel. They're all types, so I won't go to the details. Like I said, this is scissors, since I mentioned. Now, this has got rings at the back, and it's got a screw joint, if you can see. That's a screw joint, and it's curved. And as I mentioned, any instrument that has got two blades will first crush and then cut. So it's not superior to a scalpel. Scalpel is superior because it will be able to do without crushing. And crushing leads to the, these are the two blades. You can see clearly, both the blades are visible. Right. Now, it's got rings at the back, it's got a long shaft and smallish blades. And you distinguish a surgical scissors from that of a tailor by looking at the fulcrum. In the case of a tailor scissor, the fulcrum is in the center. They need a broader blade. If I take it further up, the physics of cutting is it will become finer and better. And you can actually see another scissors. It's called Potts scissors, P-O-T-T-S. We will use it during vascular surgery, where you can see a very long handle and a ridiculously sharp blade. And you can actually think that you're too wise to use something where so much of steel has been wasted. But the concept is based on the physics of cutting. You can see such a long handle. The closer I get to the tip, finer is my cut. So remember that. That's the physics. Now, if the fulcrum is, if I want to make this scissors better, I'll take it further up. This is P-O-T-T-S, Potts, suppose of apostrophe S. Now, if you really look at the scissors, they can be straight and curved. Don't remember names like Metzenbaum, Steely's, or whatever name you want. Fancy, you can give it your name also. But the important thing is they're curved and straight. That's the easiest way to remember. Right? Although for those who are very fussy about names, this is the Mayo's heavy scissors. It's Mayo's. This is Metzenbaum. Forget it. So straight and curved. The important thing is scissors cut from a point to your right to your left, from a point close to you to a point away, which is just the opposite of scalpel. The curvature is so that you always see the tip. When you're making a cut, the tip should look at you, the tip should look up. Why? Because you will know what you cut, and you'll cut what you see. See what you cut what you see. Please note it down. That's a one-liner. You'll get a few. Now, see what you cut means what? As I'm cutting, I should know what I'm cutting. As I'm cutting, I should see what I'm cutting. This is what is the purpose of curvature. The tip is either up or towards me. I hope that's clear. If I keep the tip away, I can show you with the shadow cut from a point to my right to a point to my left. If I'm using a shadow cut, see that I have to adjust to keep my incision straight. But if the tip is towards me, I can just keep going and I'll be straight. It's easier, right? I'm cutting with the scissors, which I'm extending the incision. Can you see that? I can make it into a straight line. It's just straight line. But if I do it this way, see, I'm going away from the incision. So that's the purpose of keeping curvature. So don't just, you will get it in your clinics. Somebody would say, for the cavities, for the space. That is all true. But remember, each time you should look at the tip. The tip should be looking at you or looking up. That's the purpose. Any instrument that is curved, students, that's very important. Any instrument that is curved, the tip should look at you or look up. That's a basic message I wanted to convey. Now, rest is simple. How do you hold it? Between the ring finger and the thumb, supported on the middle finger, guided by the index finger. It should be just about distal to the terminal interphalangeal joint of the ring finger, thumb. If I go too far in, I'll get stuck with it. See? If I have to move, I'll have to move with the instrument, which is the wrong thing to do. I should control the instrument rather than vice versa. In that case, vice versa would happen. That is, the instrument would control you. So what do? I'll just keep it just about hanging on. It's just about distal to the terminal interphalangeal joints of the ring finger and the thumb, supported on the middle finger, and I can actually use it. See, if I have to raise the flap, I'll keep the tip up. I have kept the tip up, and I'm cutting it, cutting it, cutting it, cutting it, cutting it, cutting it. I'm raising the flap. It's a very good instrument to raise the flap with. Another method is, which you will observe when you go into your episiotomy closures, etc., wherever. I've given the incision under vision. Now I can use the blunt side for blunt dissection. It is possible to do it, right? But don't use it to tear things, which is what a lot of people do. They just introduce and I'll show you the other side. Same thing you can do. You can practice that. That's not difficult. So undervision of cut, blunt. So straight and curved scissors, briefly. Pots I've already shown you. It's a vascular scissors. And you can see that it's got an angle. The purpose of the angle is that it will hook and cut. See now, I'm going in, it is hooking. So I'll not take the posterior wall of the vessel. So very useful. See, I've cut. So it'll all be very, very handy. See that? It'll hook and cut. Hook and cut. So it can't really take the posterior wall at all. See that? It's lifted up neatly. And if I need to dissect it further, I can do this. You will see the vascular scissors today in use. There you are. Now, that's about scissors. Now you saw the forceps in my hand, so I'll just finish with that. They again are nothing like Addison forceps, which it is, small one, or this is Mackindo forceps, but don't bother. Call them plain and tooth forceps. No names. Don't give fancy names. No, it doesn't really help. These are not made in UK or Germany to get that name. They're made very much here in India, in Chandni Chowk or Bhagirath Palace. So they can't be called Addison. This is not Addison. Looks like an Addison forceps, I can say. There are serrations. There are serrations, but they're different. There is a hole here, which is for the screw to come. You can lock it, and it allows more space to crush. Importantly, plain and tooth forceps. Purpose is very simple. Plain forceps is for vital structures like blood vessels, intestines, anything vital. Imagine anything. In fact, easier to remember, except skin and sheath. Don't use tooth forceps. Now, there is a study published where they compared holding of skin with plain forceps versus tooth forceps. And the amount of pressure you need to apply to hold the skin is good or bad enough to produce skin necrosis. So it is not atraumatic, but definitely less traumatic. But the tooth forceps has a better grip. So you don't apply too much pressure, but they have their indications. The plain forceps is for softer, delicate tissues. The tooth forceps is for the tough tissues like skin, tendons. You will see it being used in the abdomen for when you're closing the sheath. Now it's a spring-loaded instrument. What does it mean? There's a spring loaded here. So it goes back to its position as soon as you leave. See, I've got the spring into action now. And it goes back. Automatically, it springs up, opens up. See, I put the forceps inside. And what happens? See, it opens up. Therefore, a lot of people call it the dissecting forceps. The larger ones, not this one. The large, the plain forceps. I hope that's clear. The tooth forceps for skin and tendon. Plain forceps is for the softer tissues. They are spring-loaded. That's a place to hold it. I'll show you the kitchen grip, which is very commonly seen in some places. I would not name, where they hold the forceps like this. This is a wrong way to hold it. Don't never do that. A lot of you will be doing it today. I'm very used to it, watching it. I've been doing workshops for nearly 20-25 years now, including international workshops. So we see that everywhere. What is the mistake here? If I hold it, if I have to rotate the forceps, I will rotate with the forceps. It will restrict my movement. What do I do instead? I'll hold it in a classical way. I'll let the spring rest on my first web space. I'll hold it between index finger and the thumb. And that's my grip. Now, if I want to rotate the forceps, I can rotate it without rotating with it. Tooth forceps, even better because that's skin. There you are. And I can be very comfortable. Control the instrument. Control the instrument. Tooth and plain forceps. If you could zoom, please, you will show them the tooth. Brilliant. Very good. Plain tooth. Spring. Forceps done. I can't cover all, but I'll cover most of them. I say it every time and I end up covering all of them. These are commonly called the clips. These are other name for the forceps when you watch American videos, or for all those who go and work in US. pickups. So when you hear the term pickups, it's about forceps. They're called pickups. The conventional term is tooth forceps, plain forceps. Now these are called artery forceps, hemostat, or clips. They're all the same. Artery forceps would be an incorrect terminology, although it's used commonly because you can hold veins with it also. So the term artery forceps is a misnomer. So don't get confused. And again, they have spring rings at the back. They have ratchets here. And the fact they're more than one, you need only one. So why are there three? I'll just tell you. And then important thing to observe is the serrations. If you watch these serrations, beautifully zoomed, thank you. They're transfers. The transverse serrations make any instrument a better grip, but traumatic. I'll just show you another instrument, which is to compare the two. Watch it. Everything's same. It's just that the blades are long, and you can see the serrations are longitudinal. Please pay attention to every little detail that is coming your way, and don't rely on the video that you will see on the YouTube. A lot of you do that. That's not a good idea. Watch it live. Longitudinal serrations. They're less traumatic, but they're not as effective. See, the two are comparable. This is a bowel clamp because I don't want to crush the hell out of the bowel. So what do I do? What do I have? I also have space in between. You can see a little daylight through this. Yes, and one ratchet and bowel won't be crushed. We can't damage it. Now remember, I told you in the beginning, too much tile, too much crushed tissue is the cause of postoperative surgical site infections. Now, this is used for holding anything which is tough, any tissue which has to go. Don't hold a vessel with it. Don't hold a bowel with it. It will all cause damage. Why have more than one ratchets? This is a question that is answered by most in a very funny way, but the correct answer is, a lot of you say that it will be for a better grip, which is not correct. It is for the longevity of the instrument, right? So you should use one only, because after some time, you will have to use two as the instrument gets older. It's very similar to you having 32 teeth as you start somewhere, and then you keep dropping a year, every tooth, maybe 10 years, so that even at 60, 70, you have a couple of teeth left. Now, the reason for that is longevity. Okay, all you need are 4 teeth for biting and maybe 2 for biting, 4 for chewing. But then you can do with 6. Why have 32? You're supposed to drop a few every year, every 10 years. I won't say every year. Here, same logic applies. And you have an instrument which is called a needle holder. It also has ratchets, almost the same instrument, just about distal to the terminal definitive joint of the ring finger, thumb, and you have ratchets which are more than one. Why do we need more than one here? We are holding needle with it. So again, here, it's no tissue I'm holding, but still I'll need for longevity of the instrument. So the answer is longevity. And watch the serrations here, they're crisscross. You saw the longitudinal serration, you saw the transverse serrations, but now you have crisscross serrations. Can you zoom here? Focus. The crisscross serrations will allow for a better grip of the needle. Because if I have only I'll show you another one. Now you can see that it's better. In addition to the crisscross serrations, you also have a slit in the center. It's for the needle to sit. Because if I have the needle like this, it will not slip. If I have it on only the transverse serrations are present. If I'm holding the needle with the artery forceps, which is a mistake, this axis is neutralized, but this axis is not neutralized. So to neutralize both the axes for the needle, I need crisscross serrations and preferably a slit in the center, which you see in this needle holder, and that's for the needle to sit. It also is a spring, it's got ratchets at the back. I'll use one regardless of whatever. I'll use only one. But as it gets older, maybe 2, then it gets still older, 3. Now, a very common sound in the middle of the night, which is very, very popular with the residents, right? You hear the sound, sounds sweet, but it's terrible. Look at the impression it has created on the flap. So don't use all the ratchets. No. Yes. No. Yes. One ratcheted. Why are they curved? Same thing. Tie what you see and see what you tie. What did I say for the scissors? Cut what you see and see what you cut. Easy to remember. Now, naturally, if I have to see what I'm tying, I need the tip to be looking at me. That's a basic principle. Don't deviate from it. You can hold on to the flap, use the tip up approach, dissect and dissect and dissect and dissect, and you can actually hold the artery forceps in this manner. So that what can you do? You can see the tip. So why have straight artery forceps then? That's the question a lot of people ask. I think we will have one. I'll just show you. If you observe the straight artery forceps, it is straight. So if you're tying in between or you're cutting in between the two ends of anything, can you come here, please? If I'm cutting in between the two ends of anything, zoom it. Now, you see, I have more tissue on my side, less tissue on the other side. So I'll be cutting it wrongly. But if I have straight artery forceps, I'll have a sharper cut, so I can get closer. That's the purpose of straight artery forceps. And also, if you're holding on the surface, you can use the straight artery forceps. Okay. Now, finally, one last instrument before I give you the exercise, and Dr. Sukriti will observe your gallery view, is a cat's paw, which is cat's paw. So you know what is a cat's paw. It's called a self-retaining retractor. So self-retaining, how? It has got a ring. Can you go back, please? Yes, Vinay, that's good. There's a lever here. Now I'll have to unhook the lever to be able to close it. So it will be self-retaining. If I'm working alone and I don't have an assistant, I can use this by putting it inside. See that? That's my retractor. My hands are free. I don't need you at all. I can continue to work. So we got it self-retaining cat's paw. If it was alone, it will be a cat's paw. Some people also call it a mastoid retractor, which is just because they use it in mastoidectomies. But the name is self-retaining cat's paw. So there is a ring here, which you may not have this instrument, so don't worry. I'm just teaching you so that in your exam you don't falter. And it's getting recorded anyway, so you can always find it later on. I've already told you about the needle holder. Now, one more clamp, and before I show you how to get the needle on the needle holder. One is the rings there are ratchets at the back. So the fact there are more than one, I'll use one. A longitudinal serration, so it's relatively atraumatic. And as I close it, there is space in between, which allows it for occlusion. So this is a bowel occlusion clamp. It's used for bowel anastomosis. We'll show you how it works. Pot scissors I've already shown you. I'll show you the other instruments as we use them. Now the first drill was, which you will be marked for, is the putting the blade on the handle. 2, taking it off the handle. 3 is disposal of your instruments, and the 4th is how do you get the needle, the suture on the needle holder. Now, there is a particular way of doing it. You would say we've been doing it for all these years. So what's the problem? Okay, now that's the needle holder. And that's one suture. The suture pack has fortunately only one side that opens. And like universal precautions, we will always make sure that we don't handle anything. This is a classical expensive suture. If I could see the one that they will get in their practice, that will help. But importantly, I'll show you here. Now this has a cover. In a curved suture, I'll show you as we use it. Don't worry at all about it. The needle is very neatly placed. People have got better. It never used to be like this. Hold between the 1/3 and 2/3. Get it off. And now what do? I will not take the needle away. Please watch it if you're not paying attention. I'll take the wrapper away. Why? If I take the needle away, I can hurt somebody. I can cause needle stick injuries. And I'm reminding you, needle stick injuries don't just happen to your enemies. They happen to you and to your friends. And they shouldn't even happen to your enemy. Now this has to go somewhere. So I've thrown it. Now the classical way to hold a needle is at the 1/3, 2/3 junction. 1/3 means towards the, can you zoom here please? Towards the swage. Swage is where the needle is attached. And 2/3 towards the tip. So now the purpose is, if you keep 2/3 ahead of you, you can enter any skin at right angles and come out on the other side. And how far should the bite be? It should be twice the depth of the wound. So don't say 5 millimeters, 1 centimeter, 2 centimeters. That's the wrong answer. It should be twice the depth of the wound. How far do I take a bite? Twice the depth of the wound. And how far should the next suture be? Not more than that. So usually the depth of the skin, when you're suturing, is 5 millimeter. So 1 by 1 is a good formula, but it doesn't work in children. So it will be different. So twice the depth of the wound is how far I go with the width. And I'll cut the length of the suture also the same. So it's 1, 1, 1, everything. And what do? I'll hold it in this way. And remember, the functioning in surgery is at the elbow, not at the shoulder. Therefore, there is one question that is commonly asked. What is the right height of the operating table? The right height of the operating table is at the levels of the elbow of the surgeon who's operating. If he's standing with like a soldier. Now, you get an answer, especially in some specialties, that at the level of the umbilicus. But that's a wrong answer because the umbilicus goes places, you know that. So it can't be a fixed, steady reference point. The fixed, steady reference point is at the level of the elbows with the arms by the side. And what do? Look, my grip. I prefer the palm grip. I just hold it in my palm. And I'll go twice the depth is 1 centimeter here, put a counter traction, counter pressure, and I'll come out on the other side. And as I come out on the other side, what do? I'll pull it to number 2 and 3. The safest place for the needle to be on is a needle holder. That's a third one-liner. Don't put it anywhere. This is a very common mistake. And what do? I've got the needle on the needle holder. I pull it, and then I can knot. Now I'm leaving you with this much to absorb, and you have a minute to practice it and demonstrate on the gallery view. I'll now ask Sukuti to take over for marking. Yes.
WhatsApp group. They upload the pictures on the WhatsApp group of the skills.
Please upload your pictures on the WhatsApp group, and at the same time, do it just now in a gallery view. You'll be seeing. Take over, make me know.
You all can follow the instructions as we're told, and you can do the skill and post your pictures in the WhatsApp group, as well as you can switch on your video cameras so that we can see it in the gallery view. You can all switch on your video camera now.
I request all the participants to switch on their cameras and show what they've been working on. Thank you.
Can we please have it in the gallery view? Yes. Now we can see all of you performing the skill. And do take a picture once you complete. Right. Very nice. I think Kenneth Grace is trying to focus and show. Please put your ring finger through the ring of the instrument and not your index finger. Kashish. Your index finger is on the in the ring. Yes. If the camera is not working, it's okay to upload on the WhatsApp group. Only the terminal phalanx has to be passing through the ring of the instrument. Meghna, Manjunath. All are doing very well. Others can also switch on their video camera. Only keep the camera, but keep the mic muted. Udit and Shamalan, you can adjust your camera so that we can see what you're doing.
Everyone, please focus your cameras on the work that you're doing so ma'am can guide you accordingly. Thank you.
Kritika Malik, you have peeled off the banana. I think if you don't peel it off, it will be easier.
Can you please repeat? I'm sorry, I didn't get what you were trying to say.
I was saying if you peel off the banana, it won't work.
Oh. So should I use this?
One on the banana skin. On the banana skin, you can practice the suturing.
There was a sound I couldn't hear. Can you please repeat?
I was only saying that on the banana skin, you can practice the suturing.
Okay.
Part, very well done.
Yes, sir.
Mihir. Very nice. I think we move on now. Wind up, please. 10 seconds. We're taking your pictures, so please switch on your cameras. All of you, Sudeep and others, don't shy away. Take more. Yes.
Everyone, please post your pictures in the group. We can go through it later. And for now, please switch on your cameras so we can guide you accordingly.
Wonderful. Now you can get back to business. All done. We are moving on to the exercise number 4. You've done 3 in a quick time. So you all done very well. Congratulations to all of you. I think they're very, very closely done. Now, this is Kritika Malik and Parth Ladha. You can take more pictures here, Sukriti, and more of it, because this will keep changing. You can take more. You take this one first. Yes. That's it. Now, can you all put it down, please? Don't start doing it with me. That's one thing which I'll warn you against. Please stop now. When I say stop, you should just drop it. That's how it works. Because otherwise, in virtual scenario, it is very difficult to control. That's very good. So we are down to the next exercise now. That is suturing. And before I teach you about knots, I'll just take you through some principles of suturing. Now, please get back to business. If you notice anybody doing anything, we are all being noticed. What is his name? Sanjay Raj. If you are doing when I've told you to stop, that will amount to not following the instructions in the workshop. That is not good. Just drop it. You will get time to do it again. Don't worry. You will miss out otherwise. See? And then you will ask me to repeat. So that's why please stop everything. Now, this is an incision that I made, and you'll all make it from left to right, or from a point away from you to a point close to you. And now we need to close it. And as I said, we usually will go at least twice the depth of the wound away. The depth of the wound in most circumstances is about 5 millimeters. So we will be doing about 1 centimeter away from the edge, and certainly the same, not less than that distance from the previous one. So if I was to take a bite now, I've gone 1 centimeter away, and I have got I've taken 1, this is 2 and 3, and I'm done. After that, the safest place for the needle to be on is a needle holder. Don't try to let it hang around. A common mistake that happens is needle is lost somewhere here, all of you have done it, and then you start fishing it out, and that leads to infection on the needle, and you will be poking the patient again with an infected needle. Now, if I have to rotate my needle, I can do that by loosening it. So most of my movements would be, if you observe, pronation, supination. I should not use my shoulder. Shoulder is not used in surgery except when you're doing some orthopedic work, when you're pulling the bones, or when you're delivering the baby out of the womb or the uterus. So we work at the level of the elbows, make it a point. And I've taken the bites as I directed, and I can then go back if I want, which I can do if it's a mattress suture, which means going through the tip of it. If I go in the same axis, it's a vertical mattress. If I go in the same axis, see, they're all in one line. If I go in one line, it's the same axis. That is vertical mattress. Easy. Now, if I go parallel to it, it is horizontal mattress. So basically, there are two of them. So the second one is I've taken a bite. Number 2, 3, and I'm out. 1, 2, 3. Make it smooth. Don't struggle. Now the needle is, we rotate it if I want to go parallel to it. See, that's the next point here. And I'll have a similar point on the other side. So I can go parallel to this. That's called a horizontal mattress because it is horizontal. Also called a U-stitch. You can see that it's become a U. Can you zoom here, please? So this is horizontal mattress. And if I had gone in the same axis, it's vertical mattress. If I put a simple suture, which you saw, which is the best, simple, anything is the best. Now, I will need to then put a throw, not a knot. And that I'll teach you as I get back to knotting as a very important part of the workshop. Now, if so far things are clear, you can give me a thumbs up. You're all visible to me. Great. So we are together and we are on. We move on to the knotting session now, which is very, very important. And I'll keep reinforcing the suturing points as I show you the suturing. But unless you know knotting, you won't be able to close and finish. So for a moment, this takes the back seat and the knotting pad comes to my front. It is a simulator, courtesy Ethicon Johnson Johnson, where I started with the basic skills. They were the pioneers in doing it first time in the country, and I had the pleasure of being the part of it when they started. Now, this is the tissue. For some of you who have done already, you will know. I mean, one thing I would show you here before I come to knotting, because there's no point I want that you skip and you miss out. I'm taking the needle back and I will just show you something that I'm going to use effectively. For a moment, I would want the camera to come here, just for a moment. I've taken, yes, lovely. Now, this is the part I already taught you. Why is the depth of the wound? I enter, and that's number 1, 2, and 3. And with 3, I'm done. It's on the needle holder that the needle goes. Very important to keep it on the needle holder. Now I can use anything. But I wanted to show you something different here. Needle and the thread are usually towards you once you've taken a bite. And you can see, usually, the short end is away from you. That's the short end. And short end being away from you is a usual scenario. And this is what I'll take as a basis of what I've taught you. And you can see that both are at the same distance from the edge, which is twice the depth of the wound. So very clear. And now I can see this lady, Kenneth Grace, suturing. If you don't want the workshop, you can close it and go home. Otherwise, follow the instructions. You should not be doing it with me. So Kriti, keep a watch on those who are doing it. They should do when you're told. It distracts me. Pay attention to what is being taught. Then you will get time to do it. So don't be in a hurry to do that. Mirza, I'm watching it. Don't do that. It is distracting and disturbing. Just stop. So you're disturbing others too. Don't do it and don't try to be extra clever. You will get time to do it. So when you get time to do it, do it. It's good that you can do it. And I think most of you can do simple suturing. So there's no big deal about it. Learn the correct way of doing it. Okay. Now we have got to shorten away the long towards us. Now you distracted me, so I'm getting back to the knotting again. Please don't do it. Stop doing it. It will only be for your own good, I'm saying. So the one with the needle will be a thread that will be towards me and it will be the long end. The short end is usually away. So this is the tissue. And imagine the purple end to be, this is the purple end and there's the white end to the rope. And imagine this as the needle and I've gone through this tissue. As I go through it, I'll have the short end away. And I would want you to pay complete attention to the knotting session, otherwise you will not understand it. And I have a request to make, please don't start doing it with me. You will not learn it. I do it all the time, that's why I'm saying it. Don't get restless and start doing it, which is a common problem. Wait, your chance will come and you will be doing it. It's for you to do. It's a hands-on workshop and credit to the global body, which is they're trying to do. So make most of it. Don't try to rush into it. There's enough time in the day to do it. So the short end is away, long end is towards me. I'm going to teach you about knots. And if you don't pay attention, it will remain the same for future too. So pay attention. When the short end is away and the long end is towards you, what do we do? And when the long end is away, what do you do? Unless you watch it, you won't understand. Remember, we are going to use the movements of our elbow and palms in knotting. And if you notice, index finger and middle finger, these are the two fingers that are going to play a major role in knotting. When the short end is away, we're going to use an index finger throw. When the long end is away, we're going to use the middle finger throw. But how would you know this unless you pay attention? That's why I'm asking you to pay attention. Index finger, middle finger throw. This is how it's going to be. How do I hold the thread? What is a knot? What is a throw? Are they interchangeable, or is there anything that you can do to make a knot better and make it count as a secure knot? The answer to that would lie in what I'm just saying. Remember, each time that my thread crosses to the other side, it is a throw. Obviously through a loop. So this is a throw. This is not a knot. So it's a mistake. So that's a throw. And I'll cross each time. You can see the short end has come towards me. And at least two throws make one knot. Zoom here. That's a knot. And we call it the reef knot. I'll tell you why. But first thing to understand first, each time that I cross through a loop, it's a throw. And at least two throws will make one knot. And usually two will be enough. But in order to cut the threads short, I'll put a third one. And each time that I put a throw, I cross. So when I'm crossing it, it's called a square throw. And two square throws make one square knot. That's the bottom line. So each time that my threads cross, it's a throw and it's a square throw. And if they do through a loop, it'll help me make a knot. And when I cross each time, it's a square throw, and at least two square throws will make one square knot. So that's about the principles of knotting. Thirdly, so what did I teach you? First thing, a throw is not a knot. Each time that I'll cross over, it's a throw. If I do it twice, it's two square throws crossing over, and two square throws make one square knot. And square knot is also called the reef knot. It's a bottom line. This knot everybody has to know, whether he's going to become a surgeon or not going to become a surgeon. Knotting is mandatory for every doctor to know, because you may need to suture anywhere. Even if you become a psychiatrist, if you are suturing, you get a patient with a wound, although a psychiatrist would think it has nothing to do with any body, So psychiatrist is about treating no bodies, so mind, right? So that's not what would be escaping the suturing. You should learn. So each time that I put a throw, I cross. That's a square knot. Now I'll teach you how I do it. So I've told you what is a knot. Now I'm telling you how to make it. Short end is usually away from you. I've shown you in my bite. The short end will automatically be away from you. If the short end was long, you will be losing this much of thread, because after the throw is done, what do you do to this? One is you'll be taking such a long thread through it, and then I'll have to cut it. This much of thread would be lost. Therefore, keep the short end away from you and keep it short. Now let's see how do we make that throw. First of all, short end is away, long end is towards me. How do I hold it? The key is, how do I hold it? Between the ring finger and the thumb, like you meditate. I am going to use the index and the middle finger, therefore I can't hold it like this, which is another thing that a lot of you do. So hold it between the ring finger and the thumb. And I'll use, since the short end is away, I'm going to use a shorter finger. And that's not a rocket science. The shorter finger is index finger. And what do I do with the index finger? I'll draw it out like a figure of 4. Again, hold it between the ring finger and the thumb. Keep your index and middle finger free. And when the short end is away, use the smaller finger. Long end is away, use the longer, that is middle finger. Now, if I put it correctly, the short end is away from you, index finger throw. Short end is towards you, middle finger throw. That's an easier way to remember. So short end is away most of the time, so I'll normally start with an index finger throw by drawing the thread away and making a figure of 4 and advancing my left hand to hold the intersection so that it doesn't get loosened. That's a 4. So this is 4. And now my fingers are free. I'll use index finger to fish this thread out. While I'm still holding on to it, don't drop the thread. Fish it out, secure with the middle finger, and draw it out. And I'm still holding on to the intersection. And what do? I cross. I told you I'll cross so that I can make it into a square throw. Now the short end has come towards me. That's what crossing is. Now naturally the long end is away and short end is towards me. I'm going to use which finger? Middle finger. How do I put the middle finger? I'll hold the long end exactly like I was holding earlier, between the ring finger and the thumb. And the short end, I'll hold slightly differently. I'll hold it like I'll hold a dart. You've seen a dart being thrown? This is the dart. And you hold it in the index finger and the thumb and throw it like this, don't you? Like this, like this. So hold it like a dart. And this is like before. What do I do next? I wrap it around my 3 fingers. I was here. I wrap it around my 3 fingers and bring the longer thread right across, keeping a gap of 3 centimeters here, so that I can now use my middle finger without leaving this grip between the middle and ring, and this grip is also there. I'll fish out the thread. And what do? I do what is called as bedding the throw. What is bedding the throw? Don't pull it like this. Pull it by using your index fingers in the same axis. This is called bedding your throw. Clear? Show me your thumbs up. Those who could, do it. Those who could, watch it. Don't do it, please. I'm sorry. I'm repeating it once more. The short end is away from me. I'm going to use an index finger throw. How do I do it? I'll hold the thread between ring finger and the thumb, and I'll use my index finger to draw it out like a figure of 4. Hold the intersection. Use my index finger to fish it out. Secure with the middle finger. Draw it out. and I'll cross. The short end is towards me now. Since it is towards me, I'm going to hold it like I hold a dart, wrap it around my 3 fingers, bring the other one right across, secure with the middle and ring finger, and I'll cross back. Now that's the reef knot. Please put the reef knot. Your time starts now. And you'll be observed for how you do it. We're putting you on the gallery view. Now you can do it. That's what I told you. You'll get time. Let's see how you're doing it. You're being watched. Even if you have to do it correct. Vivek here. Listen. So many of them. Arrow को भी click करो. Vivek आप ले सकते हैं picture चाहे तो. All sorts of good things. That's what I want to show. Those that don't have the knotting pad can do it with the shoelaces. Pick up any shoelace that has lost its thread. I think all of you are able to do just by observing. You won't learn it. You just get hold of a shoe and do it. Done. Yeah, thumbs up. That is part. Lada. Are you all enjoying it? You can again raise your thumbs if you like to.
Yes, sir. Yes, sir.
Just keep going. There's a lot to follow. Now, I can see lots of beautifully made pads, especially the one that Rani Kumar, Ram Kumar has made. Ram Kumar K. Somebody is actually doing it on a shoe. Good. A shoe is not a primary choice. If you can get a hold of anything, like you can see lots of your friends doing it very well. Okay, so that's reef knot. I think you all could do it and then record it. And so, Kriti, could you take it for marking? They can put their pictures on the group.
Yes, sir.
Please put your pictures on the group. It will be seen. We move on to the next knot now, which is an extension of this. And when I say we're moving on, just drop the thread. And that's the kind of regimentation we need for learning. Just stop. Surgery is about discipline. Next thing happens only when we allow you. Next, we move on to the surgeon's knot. Now, what is the purpose of surgeon's knot? You must have seen If you're not, you will. If you have a tissue which has got wide apart or it's thick, it's tending, it's trying to go back, it's got a memory. So it's got a memory means I tie a knot, it may slip off. So then your professor may tell you, hold the knot. And you can actually hold the knot, which is a dangerous thing to do. It's a bad practice. Reason why, I'll tell you. For all those who have flown kites will know. Now, usually kite gives way at the knot. That's the weakest part of your thread. Right, so, and you're only as strong as your weakest part. So the weakest part which we are referring to is the knot. Never hold it, never crush it, never damage it. So what do? You can put a surgeon's knot. What is a surgeon's knot? It can be used by, anybody who's not a surgeon also. It's the name of a knot. See, what do I do for a reef knot? I'm repeating for those who have doubts. Small end away, long end towards me. That's a usual practice. Don't keep the long end away. It will be a wrong way to start. So short end away and hold it between the ring finger and the thumb. Use index finger to fish it out like a figure of 4. Hold on to the intersection. This is going to be a key. And use your index finger to fish it out. Secure with the middle finger. Bring it out and hold it back. This is a reef knot and I can cross. What is a surgeon's knot? I go through the same loop yet again and hold between the index finger and the thumb. So if I was not holding on to the intersection, this will be loosened. Now please watch it carefully as he's zooming. Can you zoom further, please? Please watch and pay attention to these two pulleys. These pulleys are taking the throw down. See that? And they work as a noose now. Now you don't need to hold it. It's going to be tight. Surgeon's knot is the most reliable knot. And I cross. Short end is towards me. And now what do I do? The short end is towards me. I'm going to use the middle finger throw, which is like holding it like a dart. Dart, dart, dart. That's how you remember it. This is the other side. Wrap it around your 3 fingers. Bring it the other side. And that's a surgeon's knot. Anybody who did not follow, I'm repeating it once again, and then you will get to do it. And this we mark. We like to see your surgeon's knot appearance. It's very easy to pick. The short end is away from you, long end is towards you. Hold between the ring finger and the thumb. Use index finger to fish it out like a figure of 4. Hold on to the intersection. Use your index finger to bring it out. Hold between the index and middle. Back again. This is second. And watch these two taking the noose down. And I cross. If I don't cross, it's a granny knot. I will not show you granny knot, otherwise you'll end up practicing it. Most surgeons do put it by mistake because that's what learning is all about. Don't put a granny knot. Granny knots are useful for knitting. Not that they are not useful. The grannies have been used for ages. But what do? They put lots of those throws and then finally they put a secure one. Anyway, we'll not go there. So that's the surgeon's throw, first throw. And then I hold the short end like a dart, wrap it around by 3 fingers, bring the other end right across. I go through it and I cross. Zoom here, please. The surgeon's knot would look like this. And we'll be able to catch it. Please put the surgeon's knot and you have 60 seconds to do it. So Kriti, get into action. Start now. Take your time. 1 minute has become 1.5 minutes now, don't worry. If you learn this knot, you master knotting. Who?
Ritika, she's doing correctly.
Ritika, you're doing very well. Keep going.
The knot by Srinidhi, it's a little loose. You can
Srinidhi, you can tighten your throw. You put it correctly to demonstrate. Correct. That's it. Good.
And you can all adjust your cameras to show us.
Parth, I can see yours, but I can't see the knot clearly. Just keep it there. Keep the camera there. So, Kriti, can you see that from close? Parth.
Yes. Can you bring it a little closer? Yes, it looks fine.
It's fine.
Ritika is also fine. It's
Ritika
a
is
leaf
fine.
snort, but
Divya.
yeah, she's struggling because the banana is.
Yeah, use something steady.
Divya, you can use something steady against.
Take
around
anything
which
around the chair, you can do it. Yeah, that's a good one by Aishwarya. Very good surgeons, not Aishwarya.
Yasin also use something stable around which you can put the knot. The bottle and the banana will keep moving.
For knotting, you need something steady.
Kashish is doing wrong.
Kashish,
Kashish, yeah, you can open it and do it again. No, you have to wrap the same thread, Kashish. Yeah, the one you're holding in your right hand. Just wrap it around your fingers. Hold it like a dart first. Yes. Now wrap it around your fingers. Bring the other one in the form of a V. No, you're crossing it. Without crossing, just make a V on your fingers. Yes. Then hold at the junction, and then loop that the thread. Yes. Bring it through the loop. And now cross. Yes. You can open and practice again. Please always make sure to cross each time after each throw.
We are planning two events, month of August. On the 5th, 22, 26. Future. Second half of the year.
Ritika, you're doing well.
For analysis medical college, just going on. And one for Gurukkul.
Mihir, you are also doing correctly. It's just that the banana, it is moving. Yes.
Not steady. Those who are doing on a banana, not steady.
Hmm. If you're sitting in the car, you can use the door handle around which you can practice. That would be
You
stable.
have been doing very well.
It's okay, you can keep practicing. Meghna, the knot is correct. Yasin, please use a steady object. The bottle will move.
Next. Very good. I think we're done with that. A lot of you did very well. It's quite amazing. So I think some of you have been watching the YouTube videos of ours and following it up. So we move on to the next knot, which is tying at depth. Something that you may have to do in order awkward situations. What I'm going to do is use this simulator. This is again courtesy Johnson & Johnson, but we can create one. Last time we had lots of students who had created. We checked for any simulators that people have made. They'll be marked for that also. And I think somebody is still continuing. Please don't do that. That's very annoying. When I say stop it, you stop it. If you're in the car now, finally decide to come out of it, sit somewhere. Okay, you can't be doing all through the day in the car. Well, that's the depth, and the hook is representing the tissue. It is important not to pluck out the vessel. You're tying at depth means you'll have to make sure that you don't pluck out the tissue. And when you have to feed the thread, always feed it from this side. A common mistake, people do it this way, this way, this way you should do it. So that it looks like a bow and a, it's a bowstring. That's a bow, it's a dhanushban and a thread. So first I'll feed it. And once I've gone through it, what do I have? I have a short end away, the long end is towards me. So which throw I'm going to use? Index finger, as you all learned beautifully. And it's the same thing, draw out a figure of 4. Now the question is, can I keep going like this? I can't go beyond a point. See that? I stop. So one finger has to go down. That is usually the right hand. And if you notice, I've kept them in a straight line. If I don't, I'll cause the tissue to be plucked out. And you can see that I've got the short end towards me now. And I can use the middle finger throw. And what do I do at this point? I'll again use my right hand after crossing the threads. It's very easy. Tighten only when you've got the distal end beyond you and keep it in the straight line. And my knot is done. If you have this simulator, if you have created it, it's okay. Otherwise, use anything to practice it. It'll be a good idea. And then I'll show you tying with the instrument. So don't worry if you don't have anything to tie at depth. I'm showing you again, principle is just the same. If I want to practice it on the same thing that you're using, for your sake I'm doing it, I'll use one end. And what do? I'll put it like this. The same thing. What do? I go beyond, advance, and then bend the throw like this. Keep it in the straight line. Don't keep it like this. It will pluck the tissue. Can you see that? It is taking the tissue away. So keep it in the straight line and go beyond it. And then the short end is towards me. So I'll put a middle finger throw. Now what do? I want my right hand to go down. So I'll cross my hands in the throw. And I'll do the same thing again. That's the tying at depth. So it's a straight line. Right? And now again I can put another if I want. The short end is away. But it's important to cross. You can please do it in 15-20 seconds and then we'll move to the instrument time, which you people already know. And then we'll get on with suturing. We will save time on this so that you can do more things. So 30 seconds for this. Please practice tying at depth the way I've just shown you. If you don't cross your threads, it will be a granny knot, remember that. And granny knot is not good for surgical work. It's good for knitting. In knitting, what they do is they keep on putting the same throws constantly, and finally they put one proper reef. Otherwise, your sweater can come off anytime. Pull one end and you can take it off.
This is not highlighted much here. This is
I'll just do that. Shift it to the virtual background of ACS.
ACS
I have it. If you want. The concept of something which I want to teach you, which you'll remember. Always imagine this as a V. Short end is away, long end is towards me. That's a V. Can you see that? If you can see that V, I have to stay within that V. Can you hold it? That's a V. Now, whatever happens, but I'll stay within the V. So what do? I wrap the thread around it, hold it, and then I'll cross. Each time that I do it, I'll cross. Another V. Can you see that? And mute yourself, please. Just hold it. This is a V. So what do? I don't go outside. I'll just stay within the V. And I'll cross back. You see that if you zoom, that's a, can you zoom please? That's a reef knot. What did I do? I stayed within the V and I crossed. These are two mandatory things. And you get the same knot. And I'm showing you the surgeon's knot also, so that you can do both in one go. Very easy. Now nobody is going to hold that thread for you. You have to imagine, because there's nothing like a V. It's just to be imagined. So now you have to do it alone. So that's my V. So 1 and 2 through the same loop. I hold on to the tip, always hold the tip, negotiate the end, And now watch it again, the two pulleys taking the noose down. Clear? Now, once again, I will rely on my V. This is the V. I won't go outside. I'll stay within the V. Hold on to the end and cross to the other side. That's a surgeon's knot with the instrument. So you learned the surgeon's knot, which is reef, and also the the instrument knot, which is a reef knot, and then a surgeon's knot. I'm repeating it. The reef for me, the short end is away, long end is towards me. That's the V. Nobody is holding it from me now. I'll take this, and I'll cross. Then V here. I'll take this, and cross back. Sorry, and cross back. Clear? And if I have to put the surgeon's throw, I'll be doing twice through the same loop. That's my V. Once, twice, and I'll cross. I'll get exactly the same knot. The noose taking it down, staying within the V, I cross back. Please put the instrument tied reef knot and then the surgeon's knot. Show it one by one, 15 seconds for each, and that will be marked. And after that, we'll get to suturing. You put the background of ECS or I give it to you? Take it from, yeah. Here also you got a background. You can see the So that's suturing. Now we have done with the tying, the simple knot, reef knot, surgeon's knot with instrument, and finally we are going to use it in our sutures, because that is what is going to be practically the purpose of learning all these skills, because eventually you have to put them to use. So I'm turning it to the, anybody who has a doubt can put it in the chat box. We'll take it later. Don't worry. If you've not understood, we'll definitely cover it. Now, I left you here. So we start with now the suturing. The principles I've already discussed, and just to make it easier, I may probably go through some of these principles again. Now, it's better to use a tooth forceps, as I said, which will give you the grip that you're looking for. I've taken a bite about 1 centimeter away from the edge, and I come out by applying counter here with my forceps. 2, and 3. And there's one more method of putting the needle back into the needle holder, which will kind of take away any trauma. And now what do? I'll have to use this.
Hashita.
Just that emblem. Now we got the bite through. We're just trying to adjust the camera. Don't worry. And now what do I have to do? I taught you the instrument tying. Don't use the needle holder. Keep the needle on the needle holder or in your vision somewhere. Use another instrument, and you can tie a surgeon's knot. See that? If I tie a surgeon's knot, I pull it in the axis, then what do? I square it. I go there and I go at right angles, and it will become steady. Now I'll go through the V again. You can see that my throw was loose. Put a surgeon's knot, tight, and it will stay here. And then I'll take a through the V, and that's my simple reef knot. And how long it should be? Same 1 centimeter that I mentioned. That's a simple bite. Now that's one, and the second one could be this is one end, this is another end, and I want to put a vertical mattress suture. I've taken one bite, which I will reverse now. I'll go back superficially in the same axis. That will be a vertical mattress. If I'm in the same axis, it's a vertical mattress. If I go parallel to it, it will be a horizontal mattress. And now, same thing. That's my imaginary V. Can you zoom here, please? Yes, that's my imaginary V, and I'll stay within this, and I'll invariably be taking a surgeon's throw, pull in the same axis, and then take the thread away at right angles. Now I'm in the V. I don't care clockwise, not anti-clockwise business, because that has got nothing to do with it. And I cut it to get the vertical mattress. The third one is a horizontal mattress. Now, why have vertical mattress first? Remember, the simple suture is the best suture. And the mattress suture has a better hemostasis. That is because it takes a deep bite, then it can take a superficial bite, so it takes care of the hemostasis better. And horizontal mattress is even better. It gives you the hemostasis ideally. It's the best hemostasis that you can get. Thirdly, if you're looking at the hemostasis to be at its best, it's a horizontal mattress, which you very commonly use in subcutaneous tissues, not in the skin. Nobody uses it in the skin because cosmetically it's not the best. Cosmetically, the best suture is, of course, I told you, simple suture is the best. If you take a vertical mattress, you get hemostasis and cosmesis both at the same time. If you take horizontal mattress, you get more hemostasis and less cosmesis. So there has got to be a balance between the two that you need to have. That is a combination of hemostasis and cosmesis. Both can be brought together by having the horizontal, the vertical mattress. Now I'm showing you the horizontal mattress. How do I show it? How do I do it? Nothing much that you need to do differently. It's holding at 1/3 towards the swage, 2/3 towards me, or towards the end of the needle. I take my first bite as usual, twice the depth of the wound, so that comes to about 1 centimeter, and then I go reverse, parallel to it. here. So I'll go parallel to it. And be careful with whatever material you've got, because it's not the human body. So I need to be absolutely parallel. 1 and 2, I'm out of it. Now that will be a slightly cockeyed horizontal mattress, but it's fine. This would have been better. Now that's V twice, and I cross. As I cross and give it a little flip to the 90 degrees, it becomes steady. So that's horizontal mattress. So please put simple, vertical, and horizontal mattress. And if I have to cut the suture, I'll just show you that. I'll cut it in front of you, because this you will be doing very commonly as interns or even otherwise. Hold on to one end. Watch it carefully. Somebody has already started doing. I think this Ritika Mittal has to stop working. They should first focus on what is being taught. That gives you -1. I hold on to one end and I'll use something like this. The suture cutting instrument is also like this. There is a scissors which is suture cutting. As you pull it, you cut it at the corner. Reason being, you don't want a lot of this thread to traverse through the tissue. So what I achieve is, I'll pull it, and better try to get a forceps that holds better, and I'll pull it. And you must always check for all the 4 limbs. 1, 2, 3, 4. Otherwise, you would have left behind part of the suture. Repeating it in the other suture. What do? I hold on to one end and cut flush. Don't cut it here. It's a wrong practice. Then you'll take the whole thread through the wound, which is contaminated part of the thread. Cut the corner, and then you just pull it out. 4 legs. Same thing here. You cut it flush somewhere. Say I cut it here. Here probably you don't have a choice, but minimum thread should go through the depth. Again, 4. One is rather long because it's a horizontal mattress. There are 4 limbs that you need to count. So that's how we remove the sutures. Please put the simple vertical mattress and horizontal mattress, and it will be recorded. It will be shown. Please record it in the camera. They record how they put the sutures. Forceps, you see them. तो forceps मत देखो, ये तो मुझे लगता है। नहीं ये तो forceps वाला है। ये तो मैं अपनी We'll move on to the suturing now, and let's start. You can put your stuff down and we move on. Just show your stuff with the whatever you've done to. So Kriti, can you just check their sutures? They're all showing now. You can start marking and start checking as I'm arranging things.
Yes, sir. Done.
Tell me.
Shrindi has done well. All of you have done well. The horizontal, Ram Kumar, vertical mattress and the simple suture. Part Lada, yes, we can see it. It's correct. Yes, Prachi, you've done it. We can see all simple, horizontal and vertical mattress. It's visible with the Katuria.
Okay, please post it in the group now. We move on to the suturing and continuous suturing. You've learned simple meters, vertical and horizontal meters both, and now we are going to see the continuous suturing, which will start from whichever end you fancy, usually from the right side, and then you can go to the left side. Same, it's very simple. You take a bite. At the end of it, I'll teach you Aberdeen knot, which you'll all practice. So this is where you need to pay attention. I've taken the distance that I told you in the beginning. The long end is towards me, the short end is away from me, and what have I done? That's my V, 1 and 2. And it stays there. That becomes my first bite. Now to go on and on, I need to give a little space, and somebody needs to follow the thread, but I'll do it. Keep going. Same distance. And if I have to do it alone, I'll hold on to the thread. And what do? I just mark it with this and keep taking the bite. Slant your thread across. And that becomes a good method of getting the same thickness, same width throughout. Now, you should not be less than the distance that I told you. If you're more, that's not a problem. You see that? I can keep it parallel and keep taking my bites. So 1 by 1, but not more than 1 centimeter, not more than 1 centimeter away from the first bite, previous bite that is. So that I'm not too far, because each suture is a triangle. And the tension at the apex is, see, you could see that it's a little close, although it's more than 1 centimeter, it's a little close. So I'll not accept it. I'll go back. Place it again. And not good. Cross. There you go. And I'll reach the other end. That's this end. So I place it again like this. Easier. When I reach this side, there's something I need to show you. You end up with a loop and a single thread. And if you could just shift your camera here, or I'll shift myself. Okay, don't worry. I'll use this as my V and do what I just taught you. And you'll see the result of that. One, and I'll cross. I have a V again. I'll hold it, and I'll cross. Now there is a, then I'll cut the suture like always. Now there is a little problem here. What do I see? I started with a single thread, but I have 3 here. So there is one thread which is continuation of this thread, and the others are just twisted loops around it. So it's not a secure knot. Now I'm just trying to give you a reason why we should have a Aberdeen knot. So now whichever is whatever. See, I pulled it. This is open. This is open. This is open. And the wound opens up and you have burst abdomen. Now you understand? So whenever you will get a burst abdomen and technique is to be looked at, this is one thing which is going to be responsible. So be clear. So I would not be doing this at the end. So I'll demonstrate to you what is it that is ideal. We put what is called an Aberdeen knot. Aberdeen is a place in Scotland known for fishermen, and it's a fisherman's knot, also called as cobbler's knot. And there's no difficulty in guessing what came first. It is not Aberdeen knot to begin with, it's cobbler's knot, which is similar. So I'll take another suture now. And how do I get a suture out of the wrapper? Same principle, that's the needle. I'll graft the needle on the needle holder, take it out and take the wrapper away, not the needle away. And I'm putting those sutures again. So that will amount to showing you second time. This is the edge. And this one would be a little faster so that I can come to the Aberdeen knot quickly. I have taken the bite. If you want to keep the needle into vision and keep it in front, that also is acceptable. The whole purpose is it should not be floating around. 1, 2. And I'll cross, pull it to one side, and that kind of stays, right? Surgeon's knot has got that beauty. Although it's a very, very tough tissue to work with because it's got a memory. It tends to go back into position. So now I have to guide my thread. What do I do? One bite will have to come close, but I will not go more than 1 centimeter away from the previous bite. That's the principle I will be adhering to. Rest is pretty similar. Can you just hold this base, please? And need assistance here, just to keep this shifting. Okay, thank you. Now rest is simple. This is my thread. I'll hold it, and where do I go? I know where I am, so I'll be easily able to maneuver it. Second, third, 1, 2, 3. There you go. I'll take a few. Put it across. And maybe the last one, and then I'll show you what is Aberdeen's knot, and I would want your attention at that time, then you can easily practice it. And that is where we have 10 marks. Other all were 5 marks each. See, I've got the loop and I've got a thread and the needle is in my needle holder. So all fixed. Now can you zoom out, please? further. And that's the, I don't know whether you can see it. If it's not visible, maybe you can now zoom in. Zoom in to give them a good look. Okay, I'll put something white here. Now you can see the loop. Yeah, that's better. So there is a thread, straight thread and a loop. So what do? I will not do the mistake which I did earlier. I'll spread this thread. It's also called a seesaw knot. I'll tell you why. Why it's called a cobbler's knot. And basically, you should remember it as Aberdeen knot in today's exercise. Aberdeen. Like I said, it's a place in Scotland. Now, so spread it between the index finger and the thumb and use your middle finger to fish it through this loop. So you fished it out. Now what do? I do a little bit of seesaw movement. You see that? It's automatically settling down. So it will bed down as you go. Gently. Don't rush through it. To create another loop, use the same thing again. Spread between the index finger and the middle. Use the middle finger. And tighten it. As you go, pull the lower thread. It's the lower thread that should be pulled. But don't pull it too hard. Don't break it. Now the second one needs to be a little tighter. I've done that. So that it sets in. Rest is very simple. Spread it with the index and the middle. And then you can do this. This is the cobbler's knot. You must have seen cobblers do that trick. But basically it's like traction on the lower end, lower thread. This is the lower thread. So what do? This is seesaw, which is a classical Aberdeen knot. In a monofilament, you need to put it at least 5 to 6 times. And finally, the step is important. You'll have to take the needle through this loop. Otherwise, it will all open up. And I'll hold this needle in my needle holder back. And I'll show you the assembly. Can you zoom here, please? Here. Don't worry, focus and zoom so that they're able to see. More? Maximum. Now you can see they're all, it's an assembly of reef knots, one after the other. And do you see what? I've got one thread now. I started with one and I got a single thread. What did I get earlier? 3. So now this is an assembly of many reef knots. But if you use a thread like proline or nylon or a monofilament, nylon, by the way, is New York, London. That's the first synthetic non-absorbable suture, which is the mother of all the synthetic sutures. And New York, London came into existence in Second World War when the supplies from the Europe stopped to US. So they created this thread. Now this is a single thread with a needle on. What do I do with that? That's very useful. I'll bury this because it will poke on the undersurface otherwise. How do I bury it? I go through the opposite side as far away as possible, pull it, and you will see that the assembly would disappear under the opposite edge of usually the rectus sheath. That's where you use. Correct? Now we pull it, cut it. So it becomes a smooth surface, nothing pokes, and it's closed. Please put the continuous sutures and finish with the Aberdeen knot. All of you can now start doing it. And we have 2 minutes, 3 minutes to do it. You'll be marked for this. This is very, very important. And display for your own sake. We'll have abdominal. Yes.
Please switch on your cameras, all of you. Others can also switch on their cameras.
ग्लव का ग्लव है क्या that was brilliant for me. बढ़िया निकल भी जाएगी और उसी स्पीड से परफेक्ट बहुत बढ़िया एक्सीलेंट नहीं बस ठीक ठीक है आगे और तीसरा रास्ता है अब तो ये कोविड टाइम ये सब कर रहे हैं ना तो रास्ते यही बढ़िया हो अभी तो सर्जरी के लिए
Ritik, you can pluck out, undo some of the sutures if the length of the suture remaining is not enough for the Aberdeen's.
I don't have another suture, so I'm using it.
Undo a few of the continuous sutures, no? So that you are left with one loop enough for the Aberdeen's. Take it backwards. Part, you can adjust your camera. We can't see you making the everything's note.
This student in 30 dress.
Nobody. So, don't. Don't handle the needle with your hands, bare hands. Use the instrument.
Minus. Don't use hands for holding the needle. That's a criminal offense. Use forceps for doing it. Use anything, any instrument. I can see this Meghna making a good knot with the everything. Try to do that, you'll do fine.
Ritika is also doing fine.
Ritika
Everybody.
is doing fine. How quickly they all picked up every knot. Really nice to see.
Even Ram Kumar is doing some. No, he's taking the needle through the knee. Finish.
Well done, Ramakumar. I need to show it on an iPad or on a paper. I can do that on a paper to save cancellation. Yes. You just tell him to do it. iPad से भी बंद करिएगा.
If anybody has any questions, you can post them in the chat or in the YouTube channel also. They all will be taken up by sir at the end.
Should be clicked on the recording. No? Click on it.
Yes.
We got 30 seconds to go so that we can move on.
Somebody asked for palm grip. Somebody asked for second.
We take on the
Yes.
Now, organizers, we will have the session on abdominal incision and closure, and after that we'll break off for lunch. Post lunch we'll have the bowel, anastomosis, vascular anastomosis, and tendon repair. So we'll have 3 sessions before, 3 after. Now this they've done well, fast, therefore we're taking abdomen straight away. I was thinking how much we'll share, but I am ready to go that distance. So I think we now stop it. Anybody who has not been able to put an Aberdeen knot can now raise his hand. And otherwise, I think we've given you the time you need to. And I can see that a lot of you have already put the Aberdeen knot. Anybody who has a difficulty, please mention in the chat box. We've received some queries from the YouTube group also. So we will take those at the end. Now, I would want your attention on the screen now. Please put your instruments down, otherwise you won't understand anything. And that's what I told you in the beginning. If you focus on what is taught, it is all very simple to understand. Remember, we have a simulator on which I'll show you abdominal incision and closure. You may not have this simulator with you, but you don't need it. Therefore, I want you to pay attention. You will still need to do it and you will be able to do it. Now, I think you should stop. That's what I need you to do. Now, let's get to the abdominal incision. For that, it is also called making an incision for laparotomy. Laparotomy is opening the abdomen. Sanjay Raj, please take your hands off the work that you're doing so that we can focus. Okay. Now, if I take a cross section of the abdomen, I'll have that's the skin. Then fascia, scarpa and camper, as you know. Scarpa is membranous and camper is the other fascia. Now I'll try to take more colors. Okay. Then you have the anterior rectus sheath, which goes right across. And there is a trick here, which I wanted to show you. That's why I drew it. That's about the rectus muscle. So you have a rectus muscle, one on each side. That's the muscle. And the sheath is dividing to enclose it and form something like this, an image, which is not very difficult to understand. I have made a posterior sheath, and you can see this as enclosing it. So there is a portion here which has got no muscle underneath. There is one here, and you have this midline. That's exactly the midline. The next structure that lies here is the peritoneum. Most of us for laparotomy prefer the midline incisions. Why? They are faster to make, and you can enter directly into the peritoneal cavity without having to cut any muscle. The blood supply comes from the flanks, like this. So naturally, this is relatively avascular. So that's a watershed area. Now, it is a white line which I am making as, see the blood supply is coming. So this is a zone which has minimum blood supply. Now the part which is here is relatively avascular, and since it's a white line, white means alba and it's a line, that means linear. It's called linea alba. Clear? So this is linea alba. It's very important to understand this. The advantage of midline incision, therefore, first point, why? Easier to give, faster to do, relatively avascular, and you can access either side of the abdominal cavity through one incision. So these are the advantages of midline incision. But the last one is the greatest advantage, which is that you can close it by what is called a mass closure technique, which does not include the muscle. So when you hear about the mass closure technique, better be clear that it is not all the layers that you take. You will just take, so this is the mass closure, where you'll just suture the linea alba in a continuous manner, finishing with an Aberdeen knot. How we do that is what I'll demonstrate to you. I wanted you to understand the reason. So one, why I'm answering now, quicker. So it's quick, avascular, provides access to either side, and it's not writing again here. Yes. So I charge it. Provides access to both the sides, relatively avascular, quick, nothing is there, completely avascular. And finally, you can close using mass closure technique, which you are going to learn today. So use your same pad which you had for this purpose. And that's how I wanted you to understand it. So we are going to learn today the midline incision, the making of it, and then the closing of it using mass closure technique, which again I'll show you what is mass closure technique. We'll just show you in this picture so that you can pay attention and understand what I'm trying to come to when I'm saying the mass closure technique. Now there is a theory of Professor Jenkins, spelled as J-A-N-Kin, Jenkins spring coil effect. What is it? He studied it on animals, then finally it's now this is what we practice today. That's why I wanted to give you a background to it. And what is the concept? This is the two sides of the rectus sheath. If you take bites at least 1.5, 1 to 1.5, you can say, some people say 2 centimeter away from the edge, and not more than 2 centimeter away from each other. So 2 by 2. And if you don't lock it and you keep going continuously, you end up producing what is called a spring coil, isn't it? That looks like a spring coil. A spring coil that you see in your pens or in your beds or whatever. So what does that spring coil do? In the immediate post-operative period, when the intra-abdominal pressure is rising, it expands to accommodate and goes synchronous with the breathing. And that is what takes care of, like a spring. So this takes care of the abdominal wall, so the burst abdominals don't happen. This is called the spring coil effect theory of Jenkins. Now, this was the background, and we will be learning it on the simulator. So now, please pay attention to this. This has got some problems, but it is by and large the best that we have. Again, courtesy Johnson & Johnson. They've been very much into academics, and that's why I like to get associated with them. This is a, you have something like the pink thing that you see on the surface. This is supposed to be skin, but you can't pinch it away. So believe it to be one thing. And in your case, you don't have this with you. So you can just make what you have as rectus sheath. What we are going to do is rectus sheath closure. We are learning mass closure. Now what do we have here? We have a little skin, then there'll be white muscle coming, and then there is a peritoneum. So we'll be cutting through the muscle here, which is a mistake in this simulator, because you saw that that linea alba will not be cutting through the muscle, but here you have to bear with it. I know that mistake is still there, so you can watch it. Now, can I have a pen to mark, please? Dr. Vivek, if you could kindly give me a pen, please. Marking pen. If you don't have it, it's okay. Or any pen will do. Suturing, any pen will do. No problem. You have it or you don't have it? Let's save time. Please get that. I'll still need it for marking later on. We all got things together, and we got it. So I'm marking the abdomen. This is the belly, and you can see at the bottom. If you could zoom out, you can show what is there. I'll take it forward. This is supposed to be the bowel, and you can see it's a big, thick balloon, which actually is something like this. It's a beautiful simulator, but it has some corrections which you need to put in, and I'll request Dr. Vivek to pass on that word. You spread it. I'm just marking it. So I marked the writing. Now we got it. Thank you. So we spread it, and I marked the incision. So this is the incision, and now I'll spread it like I showed you, and I'll use, somebody was asking what is palm grip. Hold between the index, middle finger and the thumb, and put it in your palm and use your index finger to do it at an angle of 45 degrees. I'm turning it so that you can see. I'll be uncomfortable, but you should be able to see. Spreading it, and at 45 degrees, I'll just keep going. And as I go, I made the incision from left to right. That balloon is supposed to represent the bowel, and I will try and show you how it sounds when we actually puncture it. So, but that you should not do. So I made an incision in the skin, and I have exposed the subcutaneous tissue. Now I'll use the retractor to make it easier for you to see. You can actually see the white thing here. And I'll just put it the other way around so that you can see it, and yet not, the view should be clear. Give me a moment. Okay. So the red thing that you will see will be the, what you're seeing, the subcutaneous fat now. And I'll cut through it with an angle blade. Never keep the blade straight. You will cut deeper than you want to. And you can see yeah, I think it is visible. He's trying to adjust his camera. Yes, good. That's better. Focus it now. Now I'll make the incision and spread it further. You can see the big thing that is shining is the muscle, and we just will go in between. And actually you can see that clearly. And now what am I doing? I'm trying to guard my peritoneum is below this, and I'm using the forceps by spreading it. That's the purpose of a dissecting forceps if you have a challenge. And now I can use curved scissors. You can see that I taught you tip up approach. The tip up will make that sure that you don't damage anything. And if I have to go the other way around, I'll still have the tip up. See that? So that's the tip up approach. And we have expanded the incision. Once you do that, what is visible is peritoneum. Now what is visible is peritoneum. I'm adjusting the light so that you're able to see. This is the peritoneum. So now make it a point that you lift up one end, and before you pass it on to your assistant, pinch with your finger to see that you've got no bowel in it. And that's very, very important. I'm trying to use another hemostat now after I made sure that I've pinched it. Once I've done so, I'll use the blade at an angle, not vertical. And now I open the peritoneum. Once I've opened the peritoneum, I can extend the incision either side and do my job. Once the job is done, now I'll close. Now remember one thing here. We don't close the peritoneum. It is something that you should learn here, because very many times there is a mistake that people insist on closing the peritoneum. And why don't we close the peritoneum? I'll give you the reason. One, it heals itself in less than 72 hours. And number two, if you close it, you're likely to produce more postoperative pain and adhesions. So I'm repeating, we don't close the peritoneum, it heals itself. Now, it heals itself in 24 to 48 hours, 72 hours maximum. It's a one cell layer, so don't worry too much about closing it. You know, it is otherwise insensitive, and have an issue of, just give me a moment. Now, what we are therefore going to do, we just close the sheath and believe this as a sheath. In your case, you can use only one layer, so don't worry. Please bring the camera to the angle. That is an important part. Now let's look at the sutures that are available. Zoom out, please. Zoom out, yes. Zoom out. Now, this is a synthetic suture, which is PDS. Zoom out. PDS is polyodaxon. This is there is a story about good sutures, the ideal suture. Now, if you're asked a question, what is an ideal suture? Basically, you're taught there are absorbable sutures, there are non-absorbable sutures. Okay. Then both can be synthetic or natural. The non-absorbable sutures that are natural include silk. It's natural. There's nothing else which is natural in non-absorbable sutures. Absorbable sutures, natural ones include catgut, which is made out the sheep gut. So you can't kill so many cats for this, right? And you pick up the submucosa of the intestine for making those sutures. So you need it from sheep. It's made out of sheep gut. It's called catgut, but it is not truly a catgut. It's out of the sheep gut. The ideal sutures definition was given by Sir Moynihan way back. And that says an ideal suture should be absorbable because you don't want to leave any foreign body in the body. Number two, it should be cheap, inexpensive, non-reactive, and easily available. And easy to knot, easy to take off. Every quality in no suture is available today. The closest to being the best suture is Polydaxon or PDS as you call it. This is Johnson Johnson PDS, Ethicon, which is absorbable. Now, why I'm saying this? You see, if you use catgut, it stays for 7 days. There's something called as tensile strength. I can't teach you theory here. Tensile strength is for how long it can hold on to its tension, right? Vicryl can be, which is a synthetic absorbable suture. Catgut is one synthetic natural suture, absorbable natural suture, and Vicryl is one synthetic absorbable suture. But that has a stay for 3 weeks. Now, the sheets, like the abdominal sheet, the rectus sheet, they take about 7 to 8 weeks to heal. So if you put normal Vicryl there, it's not going to last that long. So you may have the suture failing. So therefore, please understand this. This is both a theory question and a practical question, especially for those who are going to follow surgery as a career. If you use catgut, forget about it after 7 days. It's not going to be any useful. So therefore, it's used for subcutaneous tissues and it has gone out of use. Nobody uses, we don't use catgut at all. It used to be very popular once upon a time. Now, the Moynihan's ideal suture doesn't exist. So you're looking at some plan B's and plan C's. Vicryl, I said, was 2 to 3 weeks maximum. You can argue on 2 weeks or 3 weeks and you can say that, you're right either way, but it doesn't last. Now, understand, the suture is for the tissue. And rectus sheet takes about 6 to 8 weeks to heal. So if you don't put any suture which has a tensile strength for that long, you're going to fail. So you have to choose the right suture for the right wound and the right tissue. For rectus sheet, we need something that can last longer. And therefore, a lot of people use absorbable suture if they want to, Polydaxon. Non-absorbable, Prolene or nylon. As I said, nylon is New York, London. It's a suture which is the first synthetic suture, it's the mother of all. But the problem with both Prolene and both nylon is that they will stay in the body forever. They will never disappear. But they'll provide you tensile strength for a longer time. But the trouble of having them, even after nuclear holocaust, it is believed that this suture would stay, like nylon would stay. So now we have absorbable sutures with a longer tensile strength, more tensile strength, a longer duration. That's why I was saying ideally it should be absorbable. Correct? So this is the suture, which may be a single suture, it may have a loop. Now the purpose of a loop is very easy to understand. It will take away one knot. You don't need to put knot at both the ends. Remember that. I told you what is the significance of knots. Now you watch it as I took it off. This was inside it. Okay. The wrapper opens only on one side. I'll open it up, decently packed, no problem. And you will see, if I have to show you one more thing here, which I forgot. Now you look at the cuts. There's an oblique cut and there's a straight cut. Straight cut is where the needle would be. And that's where the needle is. What do? I graft the needle at 1/3, 2/3 junction and Like I taught you, take the wrapper away. And you can see that it's a loop suture. It has a loop. You won't get it, so don't worry about it. So if you have it, it's ideal, it's okay. No, nothing wrong in learning about it. The loop suture is like a loop. So you don't need to put a knot on the other side. Otherwise, you'll need to put a knot. So I'll show you with the knot and without the knot so that you don't feel lost. So I'll first show you without a loop so that you are familiar and you can use it in your situation. There was a suture which remained. Give me a vehicle, I'll just show them because they may not have the loop suture. So how are they going to do it first? And then I'll show you how do we do it with a loop. So far, so good. Anybody who has not understood, or those who have understood, thumbs up. Great. Some have raised both the thumbs up, so they've understood twice as good. That's wonderful. Now, this is a vicryl suture. Vicryl is a synthetic absorbable suture. Very good suture, but not for every purpose. You open the wrapper, and then you can see the needle on the area of straight cut. You can just open it and remove the suture. See that? So I'm showing you without loop now, and then I'll show you with the loop, which is what you don't have. That's why I'm doing it. Now, what is my first bite like? Please watch it. That's my corner, and that's the most important part of my closure. I'll take an inside out bite, at least 2 centimeters away from the edge. I told you the formula of 2 by 2, and stick to that. Inside, out. Why am I doing it? So that the knot will stay inside. If you had nylon, I would have shown nylon. That's okay. No problems, no problems. Can you hold the end, please? Yeah. And then I'll take the same bite, same distance, outside in. What that does is, my knot will go inside. Now, I'll show you, the short end is towards me. So I won't use index finger, I'll use middle finger throw straight away. And I'll push the throw in. Now the short end has gone away from me, I'll put the index finger throw, middle finger throw, index finger throw. In the Aberdeen knot I showed you, at least 6 to 8 throws are necessary. Because if you use 6 to 8, the knot is not going to slip because they have a memory, so they tend to slip. I've put about 6 throws. Now, this is my long end. The assistant will hold the thread. You don't have an assistant, so don't bother, hold it yourself. And now I'm inside, so I'll have to come out from the edge which is towards me. I take a bite inside, out, and then I'll keep going like before. Reach here and put an Aberdeen knot. Okay, I'll show you now. Okay, let me show you what I'm trying to say. You don't have the self-retaining, so don't bother. Don't try to worry about what you don't have. Do with what you have. These are difficult times. Hopefully, these times will get better, and you will see physically you will be able to see these procedures. We'll do that again with the Johnson & Johnson, and you will be able to. I can take off this. And see that? And now it's simple. I'll just keep going on and on. No locking. Locking, if anybody wants to learn, it's done if you're doing hemostatic suture. I'll show you locking, but don't do that. Locking means I'll go through the loop, which you should not do. It's not to be done because then you'll not get the spring coil effect. Okay, now I'm going to show you with the loop. Just to make it clear to you that you can do it with your stuff, whatever you have with you. I hope you have the suture. That's very, very big. I opened it again. And I'll use now the loop suture, which is, how does it help? You will just see. Something to learn, don't worry about it if you don't have it. Now what it does is it avoids a knot. How? You will just see. I'm inside out. Don't pull it. And I'll go outside in. 1, 2, and 3. Now watch what I do next. I'll pick up the loop and I'll go through the loop. So I don't need to put a knot to keep it steady there. Rest is the same. I'll go inside out. Because I want to come out. I was inside, so I can't suture like that. So now once I've done it, it's a little tricky. I would be happy to take it if there are any questions at the end, because it can be a little bit of a challenge to see it virtually, but that we are doing our best. Hopefully it's working. Now it's simple. I'll go at a distance of at least 2 centimeters away from the edge. It's more important to keep that distance for the purpose of adequate spring coil effect, which you learned. Just keep following as I do. And now what do? I'll use the thread as a guide. And I'll manage. That allows me to give traction as I want, so I don't need assistance there. Because you're alone, so I'm trying to teach you how are you going to do it. You may have the luxury of an assistant in the operation theater. But if you don't have it, you need to still do it. I'm very sure about the margin that I take. It should be at least 2 centimeters away. Keep it. Some people say up to 1 centimeter. Some say 1.5. The reason is to go to the stronger part of the linea alba, where you get type 1 collagen, which is the best and the healing part. I'll keep going. I'll put it right across. Use this trick which I'm showing you in continuous sutures. Place it parallel to the previous one and get the same distance. It's easy then. If they're closer to each other, no problem, but they should be wide. I won't say wider the better, but to some extent, yes. I'm just about to reach where I need to go to the other end, and you will see how I'll use the Aberdeen knot to wrap up the complete thing. You already know why Aberdeen knot and why not a simple knot. And I'll also show you how to bury. Now I've reached the end. Maybe I'll go one step further. That's the axis. That's my last bite. Now I'll put the Aberdeen knot. This is the loop. Now it's more clearly visible. I'll spread it between the index finger and the thumb. Draw it like this, go for the seesaw movement and it settles. Second one, and make second one tighter so that it stays. Then the third, fourth, fifth, sixth, seventh, and eighth. And if I don't stop myself, I'll put at least 10. So that you start enjoying it. You can see I put deliberately to make you see that they're all reef knots. Yes, beautifully seen. They're all reef knots and you can be sure about the chain. It is going nowhere. Now what do? It's a barrier, which you all did. You'll find its use. Go away to the opposite side. Take a bite far away under the opposite leaf of the sheath and you will see that you'll have no suture outside. Right? So that's what is burying it. It's a thick assembly, as you can see, and it can actually cause a lot of discomfort to the patient. So therefore, we need to do that. And this only indicates I could have gone a little farther. There's a slightly longish assembly. I'll do that again.
Artery.
Give me a moment. I want you to learn the correct thing. Right, so I'll go farther than that. I want to bury it completely so that the patient doesn't have any assembly poking on the inner side and hurting. So what do you see? It's disappeared completely. And now I'm happy. You don't see any suture knots anywhere. It's just disappeared. That's how you're going to close the abdomen and use your own suture and your own cut for doing it. Now your time has started. That's Aberdeen knot, abdominal wall closure, theory and practical, the spring coil effect theory of Jenkins, and also the concept of closure, making a midline incision, and almost everything is clear. Please start doing it. If there are any questions, you can post. After this exercise, you'll be marked. It's a real important one, and I'll want Sukriti to look at each one of yours performance so that we can make a record of it. Over to Dr. Sukriti now.
Kritika, you can adjust the camera so that we can see where you're working and what you're working at. Okay. Same for Rishikesh also. Just adjust the camera so that we can see you working. Very nice, Yasin. Divya, actually, your even the middle phalanx is going through the ring, and it's the index finger. Yes, it should be the ring finger through the ring. Yes, sitting at the terminal phalanx. Srinidhi, you can choose the straight incision that you have made for practicing abdominal wall closure.
It's not that deep. Is that okay?
Yeah, that's okay, no problem.
Okay, okay. Thank you.
You all can switch on your cameras.
स्कोप वाले जानबूझ के जरूर डाले जाना है आज रजिस्ट्रेशन का फॉर्म निकाल दीजिए शुरू में ठीक है
Yes, sir. Abhinav, that's a kitchen grip which sir had demonstrated. The forceps in your left hand. Please correct your handling of the instrument, Abhinav. That's a kitchen grip. It should be resting on the first web space. Yes. Now it's right. Please correct your handling of the instrument, Abhinav. That's a kitchen grip. It should be resting on the first web space. Yes. Now it's right. Please correct your handling of the instrument, Abhinav. That's a kitchen grip. It should be resting on the first web space. Yes. Now it's right. Divya, also you're using your hand, holding the forceps in the kitchen grip. Change your grip. Yes. No, that's a kitchen grip. The instrument should be resting on your first web space. First web space.
It's going to be 2, so you continue doing it till you finish. And we will start with the next session at 2:30. So 2:30 we'll reassemble. Organizers, I think they can continue doing it, and we will check them at 2:30. So that gives them half an hour to wind up on having a quick lunch or whatever. And then 2:30 we'll start all over again. Right?
Okay, sir. Okay. Okay, I request everyone to you can now practice your sutures and have a lunch break as well, and rejoin the meeting at 2:30, and sir will continue from then. Thank you.
I hope you're all back. We'll mark you for, Supati, can you just mark them for their notes now?
They've all shared their the photographs also in the WhatsApp group. Yes, Yasin, it's beautifully done. You could have used that technique which I was showing to, parallelly keep the suture so that it comes distant from the edge. It's more symmetrical looking. But nicely done. Others, if they've done it, can also show it.
Welcome back. We are starting now with the bowel anastomosis. In fact, this is not, you would not have that kind of a bowel which we use generally. So I'll use the iPad first to show you what exactly is expected and some basic steps that you must learn. All your mask closure, abdomen, there were 4 or 5 questions on the YouTube, which I'll address immediately so that we don't lose track. The first one was regarding whether we can use PDS or absorbable or non-absorbable for mask closure. The answer is, although I've given it, the answer is if you have the facility, PDS is better. It's a suture that should be available. But remember, an ideal suture, I'm repeating, should be monofilament, non-reactive, easily available, inexpensive, non-reactive. So all that, okay, I'll tell you on the iPad only. So in the screen, yeah, it is visible, so it will be easy for me to tell you. I'll answer all, they have 7 or 8 questions. They go in one quick moment, I'll finish. So for mask closure, you know what you're closing? You're closing the rectus sheath. You know, it takes at least 7 to 8 weeks to heal. So you have to put a suture which can last that long. And its tensile strength would last that long. I hope all are back. Organizers, you all had your lunch, etc. because you're organizing for everybody. So I hope all are back. Can somebody reply?
Yes, sir. All of them are back. You may please begin.
Yeah, great. So rectus sheath takes about 7 to 8 weeks. So we have to look for any suture that can last that long. Plus, it should be a monofilament. I told you what is the definition of an ideal suture. Monofilament, non-reactive, or at least minimal reaction. Third, there is something called as a burst strength, tension strength, tensile strength, sorry. All these terms are, I'm not trying to get in there, but you should understand the suture should last that long and should be strong enough. Non-reactive, thirdly, it should be preferably, I'm saying preferably, monofilament I've already told you, non-reactive, inexpensive. This is Sir Moynihan's definition. So I'm defining the ideal suture for you. It should be easily available, easy to knot. Now we don't have any suture available, which has all these qualities. So closest to the qualities that we have here, I mentioned about absorbable, that is polydaxon, which is synthetic. And because it is synthetic, there is minimum reaction. With any animal source, animal protein or collagen source, which you have, say, in catgut, you will have reaction because it's being put into human body. So PDS doesn't have that reaction, so synthetic is better. Then it should have the tensile strength, which it has nearly 6 to 8 weeks, so it's good enough. And then finally, it is, of course, there's a little bit of a challenge to knot it, but you saw that it is possible to do with 6 to 8 throws, not knots, that you can actually achieve what you're trying to achieve. Now, if you have all these qualities, then PDS is an ideal suture. But if you don't have PDS, all I mentioned was the second best is a non-absorbable, at least the tensile strength would be good enough, no? So in that somebody has asked a question. So polypropylene, which is proline, can also be used. Nylon, which is non-absorbable, can also be used. But it doesn't meet which particular characteristic of an ideal suture, which I put now, absorbable. It is not absorbable. so that it doesn't meet all the requirements of an ideal suture, but if it is, if you need to, I mean, it's certainly better than using the sutures like Vicryl or other sutures. So that's the answer to the question. Second question that somebody asked was, when you're putting a knot, what I'm using in reef knot as a second throw, which is a middle finger throw, so you are not paying attention. Can we use the same for the first? You can't. It's not about what I use first and what I use second. It's about which end is towards me, which end is away from me. If I have the short end, I'm repeating it because that confusion should not, away from me, should not last. Away. I have to use the short end to rotate, so I'll use shorter finger, which is index finger throw. If the short end is towards me or the long end is away, so I'll use the term short end towards me. Then I'll use a middle finger throw, which was the second throw that you're talking about. There's no question of doing it just because you like to put it this way. Most people put every time a middle finger throw because that's one throw that everybody learns quickly. But the problem is you end up producing a granny knot. After the whole workshop is over, I'll show you what is a granny knot. I didn't want to show you that, otherwise you'll start practicing it. And that's a wrong thing to do. It's a knot you should not use. So why should I make you practice that? So don't use the second throw as first throw. So that question is also answered. I've answered all the four. Is there any other question in the YouTube group? Because this group I can still check. We have some questions. We'll take them at the end. Now I'm teaching you about the bowel now. And I would want you to pay attention. Remember, whether it is skin or a vessel, we always evert as we suture. Because if you invert the skin, it won't heal. Therefore, bowel, in skin and vessel, you always evert. But in bowel alone, you invert. Must remember this. So for bowel, we'd like it to go inwards so that the mucosa stays inside. If the mucosa is pouting, it's a bad anastomosis or bad closure of the bowel. Because with the kind of bowel that we have, I may be able to show you anastomosis, but definitely perforation I'll show you definitely. So bowel you invert, and skin you evert, and also vessel, blood vessel, which we'll do, you will learn that we always evert. Coming to the next point, remember a bowel has three layers: serosa, muscle or submucosa here, and mucosa, and we have the same on the other side. So when you are trying to bring them together, remember one thing: this is one end of the bowel, this is another end of the bowel. You must remember that mucosa should not be pouting. That's one cardinal principle you should remember. Number two, you must also know which is the strongest part of the bowel. The strongest part of the bowel is submucosa, which is in green here. And our aim is to get the submucosa aligned on both the sides. So which is the strongest layer of the bowel? You can repeat by shouting. If this was a class, I normally ask students to shout back. You can shout to your tilt, submucosa. So no confusion about it. We should bring the submucosa of both sides together. That is the whole idea. Therefore, instead of two-layered repair, which is what was popular earlier, we do what is called a single-layered extramucosal repair. Single-layered extramucosal repair, which is what I'll show you. With thumbs up, you can show me. So far, it's clear. Good. So now imagine I'm doing, this is the anterior surface, this is the posterior surface. What will be my bite? I will avoid mucosa. If I take mucosa, it will be a bad suture. And I'll usually go about 3 to 5 millimeters away from the edge. And how far should be the next bite? 3 to 5 millimeters. Same principle which I taught you earlier. No confusion. So my bite goes, my thread is going like this through the submucosa, avoiding the mucosa this way, and I'm done. I have to show you from the other side. Take the submucosa, not the mucosa. So what will I have? At the end, mucosa unsutured. It will be here, it's a little close, so I'll just show you so that you don't have a confusion. Mucosa is here. Avoid the mucosa. That's the whole purpose. Clear? Thumbs up? Good. So that's one thing you need to remember, which we are going to practice today. Number 2. Okay, I can see lots of thumbs up. It's wonderful to see. A very bright batch. I'm so happy. There are about 1,500 students doing with you right now. And the last time we did a skill workshop, we had 2,000, but that was planned much in advance. So credit to all of you, also the way it has been organized, everything, so that you can all learn at the same time. It's a challenge, but always take on a challenge. Now that's called single-layered extramucosal bowel anastomosis. No issues at all? Good. Now let's go a step further. One more thing I want to teach you here, which is relating to the end which has got the mesentery and the end which doesn't have the mesentery. Remember, bowel has mesentery only on one side, so therefore there is an end which is called as mesenteric border, and the one which is called anti-mesenteric border. The one which is with mesentery. Now, which is more important? Naturally, both are important, but between the two of them, the mesenteric border is more important because it is what is providing the blood supply. And do you know what is the major reason for anastomosis failing? Tension, ischemia, and pouting of mucosa. If you remember these 3, you will be good. And I'll just show you what do I mean by tension. Because tension also produces ischemia. The most important thing for the bowel to heal is good blood supply and good approximation. Now I'll show you. Tension is bad. Ischemia, bad. Pouting of mucosa, bad. All these 3. Now, tension in the tissue or in the mind of the surgeon, both, they produce the same damage. Okay, therefore, you need to be relaxed, but not too relaxed. Ischemia happens if you tie off all the supply, and mucosa would pout if you don't go extramucosal. So these 3 things are very easy to learn. So what do I do? If I have to resect a part of the bowel, that's the mesenteric side. So if I have to apply the bowel clamp, which I showed you, I'll try to have more of the mesenteric side. in the clamp. So my clamp would be placed like this or like this, naturally like this, so that I can have more of this, less of this. Is that clear? Thumbs up if it's clear. So if I'm applying clamp, I'll just apply like this, sorry, like this and like this, so that I have maximum length of mesentery and a little less of anti-mesentery, because the blood supply comes like this. I'll show you. If you see the cross section of the bowel, the blood supply comes like this from both the sides. So this is the mesenteric side. So anti-mesenteric side will have the watershed area. That's why most perforations happen on the anti-mesenteric border. You must remember this. That is the reason, because the blood supply is minimum there. Well, that's it. And now we get on with what we are going to do. We are going to use absorbable suture for the same logic. And bowel would heal in 7 to 10 days, maximum 15 days. So I will use absorbable synthetic. Synthetic is always better. I don't use catgut at all, so I'll be very frank with you, and I will use Vicryl. And since I'm going to use very thin bites, I will use 3O Vicryl. Remember, the more O's, thinner it is. 6O is thinner than 3O. Don't say first is 1O is not the thinnest, it's the thickest. 2O, slightly thinner. 3O, thinner. 6O, very thin. 8O, you can't see. So you'll need a microscope or a corneal loop. 14O doesn't exist. All right? It's so thin that it doesn't exist. So you can't use it. Maybe somebody can keep doing. You heard the story of the king and that boy? It is wearing the clothes which are not visible. You can't see, they're so thin. But actually he's wearing nothing. So that's what it is. So we'll use 3O Vicryl. And now with this we will move on to the practical. Any questions so far? I'll be happy to answer. But this must be understood. Otherwise you won't understand the bowel. Great. So we get on with it. Thank you. That's the, let me change the mode and we move on. Can I have the marker pen here? Yeah. Now you can see the blood vessels. You can draw a few more if you want. Now these are the blood vessels. So this is the mesenteric side. That's the anti-mesenteric side. Practically, therefore, how would I apply the clamp? And I'm going to use it for making you understand yet again. That's a bowel clamp. Is it visible to you? Good. Now that's a bowel clamp, which is longitudinal serrations, space in between, and you can apply it. Now what do? I'll have to apply it if I'm doing from this side, this way, so that I have more of this side rather than this way. So once I'll cut, I'll have more of anti-mesenteric side. So blood supply would be a challenge, but the blood supply would be minimum here. And the minimum blood supply is here. You can see I was right. Most of the perforations happen at the anti-mesenteric border. So it has happened already. You can see that? That's the hole. And
It has been powered in. You have to connect it.
just let it be because the light is still good. Now that's the wrong way of doing it. So the correct way would be, I'll be putting it with more of mesenteric border, and I'll try to go right across just the bowel. Don't take the mesentery in it, which is a mistake that a lot of people make. Now the next step is important, and I would want you to pay attention. This is mesentery, and it has got 2 layers. Now this is mesentery, and it's got 2 layers. Now what I would show you is the 2 layers first. So on the other side, I will put a clamp the same way. I'll try to have more of the these are the clamps. This is not a classical one, this is the classical one. All right. We'll try to use the vascular one maybe. Now what do I do? This is the peritoneum. And if you could zoom a little, please. Now what do? I make a little cut here. Which is to open up the mesentery. This is, I'm showing a bonus. It's not a part of the deal. Because I watch that you are good students. So I'm very fond of students who are interested in what they do. So that's what I'm doing. That's my weakness for students. So I made a little cut, and there will be 2 layers as I show you. Never touch the artery forceps right across. You can see that there are 2 layers. Dr. Vivek, you can record this if you want. I made the mesentery 2 layers for you. Please come closer and you can record. For getting a similar one made, I just made it out of glove. Right, now what have I done? I've dissected the part which I need to dissect. And there is a posterior layer still there. And I will not need to go into the vessel. I need to ligate them individually. Once I do that, I can avoid damage to the vessels, because actually there will be vessels in between. And by thrusting the artery forceps, which a lot of students do, especially residents, they must have seen, and they push through it, which is a wrong way to do it. I've just shown you. And then they want to ligate it here. You ligate
I guess there is some technical glitch. Try to stay there.
There are some internet issues. We will be reconnecting soon.
So we are back. Now, camera.
Video mode, video so log it your camera. Log it, you've already connected. Live finishing. अच्छा इसमें आ रहा है उसको पिन कर दे.
So, I'm audible? Okay, great. So we are working on the, don't worry, it might happen again also. I'm ligating the, so there we are. We will just ligate the concerned vessel before we resect the mesentery along with the bowel that has to go. I've ligated it. And this is just for demonstration because you may not have the mesentery. I just made it myself. So we have to do on both the sides. These vessels can actually bleed. You will start from the anastomosis only, don't worry. I'm just demonstrating it for the benefit of at least teaching you what exactly am I trying to do. So once I have ligated both ends of the vessel, it's called ligation in continuity. If you cut and ligate, it's called cut and tie method. So I've got to go now in between the two sutures and I'm done. Then I'll extend it right up and I've reached up to the bowel. There you are. Now I've been told by Dr. Vivek from Johnson & Johnson that you can do without anastomosis, but since I promised you and we had announced it, we'll go for it. So this is the segment which I am referring to as a bad segment, which has got a hole here. You could see that. This is a segment. So I'm going to resect. And what did I do before resecting it? I made it a point that I've got the mesentery ligated. So mesentery is coming with it. So there's a little window left here, which you can see very clearly. Now I will cut the part of the bowel which has got to go with the mesentery. This was just to demonstrate. So we will save time and I will cut the bowel. Looks like a very good simulator, which can work out very well. But if you use a blade, it will be sharper. I was not sure about it. So, well, I'll need some assistance. So what you can do is freshen the edges. You can use any tube after this so that you're comfortable. Now let me. No problem. Blade. I'm trying to freshen the edges so that they are sharp. That is what I wanted. And it should be done with after stabilizing it. You can use just two ends of the. Okay. I'm just for the sake of demonstration, I've shown you. Let me just freshen the edges so that you are able to understand it more clearly. You have a sharper cut. Always use a blade. This is silicone, so I'll use a camera off, please. That's enough. On, please. So these are the two ends of the bowel. And I'm going to now anastomosis. I'm trying to fix it. What suture I'm going to use? 30 Y curve, which I have right here. You can use whatever you have. Don't worry about it. This is just for demonstration. Pure vital. Hold on to the needle. And once again, take just the wrapper away. Now, how do I do it? It's very simple. You will do it as soon as I have done the initial few sutures. My bite is extra mucosal. So imagine the innermost layer. I'll show you what is mucosa. Avoid that. Just avoid the innermost layer. And take a bite at least. Yes. 3 millimeters to 5 millimeters away. It's a thicker tube. So we are applying just a stay now. Stay means we don't tie the knot. We just hold it. But that also is extra mucosa. You can watch my videos on YouTube, again done for the Ethicon. There are lots of Gurukkul videos also of how we do it on a porcine bowel. This is a synthetic material. We don't have access to anything these days. So I'm just removing the clamp because this bowel is neither going to bleed nor going to leak. Can I do it? Now we'll take the other stay suture, which will again be extra mucosal. Try to do as much as you can. There are limitations. Last time we made it out of the glove and we had 2 layers done. So you can make 2 layers, bowel in a glove in a glove. That comes out reasonably well. That's the second stay. I need some light here for me to see. Hold it. So there are 2 stay sutures now, which will help me keep it taut. Okay, now starts the anastomosis, and I'm doing extra mucosal. By holding on to the serosa and avoiding the mucosa. The innermost layer is mucosa. If you want to see, this is the innermost layer. That's mucosa. And I'll go outside. And I'll keep a distance of, as I said, 3 to 5 millimeters, which is very, very tiny. Can you just hold the skin? Just hold it. No, lift it. Push it. That's better. 2 throws, and I cross up the surgeon's knot. I cross. Cut, please. Okay. You hold that line. Cut. We cut it usually, as you can see, very small. And there is a trick to it. Put the forceps in. Avoid the mucosa. See, how do I avoid it? I just go outside to the muscularis layer, which you can barely see. Surgeon's knot and crossing. This is extra mucosa. Interrupted, single layered anastomosis of the bowel. Now see, how do I negotiate with my needle? I negotiate like this. So I will skip the mucosa. That's the trick. Nothing else. And the way to do it is hold on to the serosa. You hold on to the outermost layer, it automatically drops. See that that's thick enough for you, and you just avoid the mucus. If you stay focused, you will be able to see it. It's not the ideal world. It's a new normal. We are all struggling, but never give up. So we are persisting with all the workshops, the webinars at Gurukkul. They're happening regularly. And our conference is 14th to 17th of August. Register early because we'll have limited seats this time. Last time in our conference, the master classes, we had nearly 2,100 students. So we had a package for all of them. This time we won't have it, and YouTube is not a great idea. Not the best, of course. And we want you to be visible. So please register quickly. I think Sukriti must be in the process of sending me the registrations. The dates have already been announced, so I'm telling you the dates. Don't miss out. Register quickly. And that will take care of your MS exam, MBBS exam, MRCS exam. Everything will be covered. It's a 4 days conference like every year. See what I'm doing? Just that this bowel is neither human nor porcine. It looks like that of an elephant. So the suture is tiny and it will take a while before I reach the other end. And the porcine gut, by now I would have at the other end, but doesn't matter. Gives you more space to do it. And I'll just show you. How do we go to the posterior? Once I show you that, then you can continue to do it. Don't worry. The fruit of patience is sweet. Always have it. Now, 30. I have. We are normally able to do one anastomosis with one suture. So I'm doing just one side and I'm not yet done. Don't worry. We are ready. See, that's how I avoid. If you can, yeah, I think it is visible. You can zoom a little. That's how I avoid the mucosa. That's fine. There you are. And on this side, I'll do the same thing. Just that's a trick. Rest you won't have to do anything big. Surgeon's not crossing. Cross. And just before I reach the end, I must be careful because you must be very, very careful at the curves. You read that in the mountains. See that? I avoided that before. I'll avoid it here too. Now I've reached the stay suture. Cross. It's all surgeons, not with instruments. How do I go to the other side now? I have two stage sutures. Can you throw light here, please? These are the two stage sutures. I'll use a long curved artery forceps. For any instrument, just hold it. Go underneath. I'm sure this will be fed into my. So I have released that artery. You don't have pitching of the bowel in real life, so it's easy. Now I've got the grip of it, and then I'll pull it this way. All I have is the other side available. I'll just keep going. After tying off this stay suture, which was my cord. I'll reverse it in a manner which I just showed you. And I'll keep it long. The only thing I've done is I've tied it. There you are. Now it is the same thing which I'm going to do on this side. Right? I can actually see that I have closed the layer which was there earlier. And you can clearly see that there are no sutures visible. Can you zoom here, please? Without sleeping, focus. Focus, please. Next. Next one is the broken. Focus करो. Blood है ना? Focus करो. This is better. This is it. Now you can see that we have done the anterior layer and I have gone backwards. And you can see that there is no suture visible because I have avoided the mucosa. And there's a layer of mucosa which is covering the entire thing. That's the ideal way to do it. And now I'll just go anterior. And that's the job done. So please start doing it now. You can start doing it. I've shown you one layer. Now, I'll just show you the posterior layer and then I'll show you with the gloves. Let me finish. If you have got gloves, you can take two sides of the glove and do it. Now I'm going on the posterior side the same way. Just take two gloves and do it. You want me to do it on the glove, I'll do that. But first, let me finish this. For those who want to watch it, they can still watch it. Wait. I'm avoiding the new code. Dr. Vivek, that's your bowel silicone. You can make it better.
Yeah, it's not coming well.
You've used that as before. I'm just trying to show you how it becomes good. It's not just a tube, so they don't understand. You need to have tube in a tube, like I did with the glove, right? What that does is that with the appearance, see now, I made it into an extra mucosa. Let's show them with the glove. So that's what they are doing. This.
But Bender is claiming same sir कि they have made it up to the means extra mucosal can be done. ऐसा है या नहीं है?
No. You can see in front of
Little more.
it's there once in a while. You can find it. Otherwise, and it's easy to make.
Yeah.
I can guide them.
So two separate layer, one over the
See
other.
now this is it. Here it's available.
Yeah. So somewhere it's thin and somewhere it's thick.
It's better to put tube in a tube.
Yeah.
Simple. And no rocket science. Actually, if you know what you're doing, most of the time they don't. Anyway, we'll finish this and I'll show them the bottle. The purpose is they get an idea of it. That's our relation for you. Now we can have a layer. There are places where it is possible, like they put a thick one here. There are places where they have. Instruments made.
Usually for a driver.
No, but I've used it. No problem. You can just get better. That's external. Vivek, this is it. Notice Dr. Vivek.
Yes, sir.
You can see the external part now. Just try to show you. See, this is a bit here. So you can look by.
It's good to have those uniform layers, one over the
Yeah,
other.
that's it. The principle is, and they should have different color.
Different color.
That's it. No rocket science. They try too much, they mess it up. This is thin part now, see? And there is a part here. Very thin. Some places it's okay.
We try to make the line
Let's try thin. No problem. It's still tender and straight. You should be able to do it. In spite of it. Almost there, but I've shown that. There you go. Next time really easy because both sides are thick. Crossing it each time, please remember to do that. I'll reach the other end and I'll tie the suture. That's as simple as that. Cut this. Now I'm just left with a stay suture, which I will tie and I'm done. And the short end is towards me, so I'm trying to use a middle finger through. Somebody was asking. Away, index. Towards me, middle. And I have finished. That's the bowel, and you can give it a leak test. The back side. Now I'll do it with the glove. That's what you want. Keep the vessel ready. I'll just show you the closure of the perforation, which is something you will do anytime in emergency. You need it.
So that they can practice.
This is what we do.
this double layer of
Beautifully done.
different.
Different colors. The last time I did that, we painted. Just show. ये भी कट कर लेना I think one of the free here For all those who are using glove, they can see what I'm doing with the glove. Can I have your attention? Can I have your attention just for a moment, please? Now I have created something here. This is the anastomosis that you saw. Now I'm showing you something with a glove so that you can practice without any trouble. I put a green glove outside and the white inside. The white is the mucosa. All of you pay attention. It will take just a moment and then you can continue. I'll try and show you what I'm doing by using a bigger suture so that you're able to see. Please pay attention. The steps are the same. I'll hold on to the serosa and avoid the mucosa. And that's my first stay. Now the second stay is on this side. If you see, I take just the green. Just the green. Sorry about that. And these are two stay sutures. One here, one here. I think you can see that. Now, I'll take at a distance of 3 to 5 millimeters. This is mucosa for you. We'll avoid that, and I'll take mucosa, avoid the mucosa on the other side too. And rest is over and over. And when I reach the other side, I'll just flip it over and do the posterior side. That's what I did. And you please watch it as I go. The distance is shown more here in the interest of time. Otherwise, it's the same, 3 to 5 centimeters. In fact, minimum. This is extra mucosa. Just pay attention. 2 more minutes and you will get a lot of time to do it. We're doing fine, so you will see tendon also, vessel also. Today is going to be a feast. If that's what you believe in, at least. One more. Any. All I'm doing is avoiding the white, which is mucosa, and taking the green, which is serosa and some mucosa. So don't have to worry. I'm trying to use a thicker suture so that you can see. No problem. I'm showing you with what you can have at home rather than what I have here. So that is to just make it easier for you to understand. Now that's it. I'll hold on to serosa only, and I'll take just the serosa. So you see that I'm constantly avoiding mucosa, and that's not difficult. When you see a normal layer, it falls. And if you see my videos on YouTube, it's very clearly seen even in a porcine gut. Not a challenge, cut please. The thing is a problem here. It's not coming out. I'm going over and over, and I'll show you how do I flip again, so that you have a revision of what you just saw. Surgeons not each time. That's why I practice all the time. I teach my residents to use that most of the time. That's us holding onto the serosa, the mucosa drops away. Not difficult to learn. Doing it at home. And you don't need fancy simulators, mind you. You need to know the thing. And all those who are doing it on any tube can actually use gloves. It's much better. I'm just demonstrating the same. Hold on to the serosa, put a glove in a glove, paint the inner one red, that's mucosa. Or blue, if that's mucosa. One more lesson here, never give up. Circumstances shouldn't force you to change it. And you can see that because I've been very carefully avoided, and I'm down to the other end. Soon I'll be flipping over, which you will see. Let's get this there. So I've reached the end, and I'll show you what do I do next to flip it, which you did earlier. Light again. Just stay there. Light again. I take the artery forceps underneath, and I'll be fed by the stay on the other side. Wait. We need to put somewhere. What do? I flip across. And now what you see is the same thing that you did earlier. I'll just put one for you, one for the road. And then you carry on. There you are. See? You see nowhere. Actually, you can do an audit of what you've done. You can see that it's all mucosa is free. Zoom, please. That's the mucosa, which is free. There's been extra mucosa. That's the best way to audit your work. Now I'll keep going over and over. Now this is going to be a very important session where we'll mark you for all your innovations. Once I've flipped over, I'll tie it. And I'll hold it. Now, the rest is simple. I'll go over and over again. And now please start your work again. Start doing it. I'll just be doing the same thing and reaching here and tying it off. That's it. So now we can all do it. We all learned the single layer extramucosal bowel anastomosis. And we can see you all start doing it. Much better. Thank you. That's what needed. But it makes it clearer than the silicone. You agree, Dr. Vivek?
Yeah, yeah, right. Because the layers are not clearly defined.
It's what is needed, and it's not difficult to make. Now, if I stick the two inside, that's one layer then. Okay. I mean, I just need to put some Fevikwik in between the two. That becomes a big bowel to demonstrate on. And it's easily available. That's what you should look at. We've got lots of models, as I said, on the YouTube, which are going for patenting. Hernia, gallbladder, also of neck dissection, modified radical mastectomy, inguinal block dissection, shoulder hernia repair, beautifully shown in the model. We got many people to get back on this. They're all there. We made those and we sent it for patenting, as I said. They're almost patented. Not difficult to make. Yeah, basically they can make it at home and practice. That's the whole idea. Now that is completed if you see on this side. So finally we are done, and I think you can do it too. That's the That's the anastomosis. Done with gloves. The glove inside a glove. I think a lot of you are doing with the gloves. That's a good thing to see.
Few of them are doing very nicely, sir.
Yeah, we can see a lot of you doing very well. This is Ritika Mittal. Ritika, you are very good. And Dr. Ram, you are also doing very well.
So we use it, create, and Artery Forceps, it means that
Don't hurry, no issues. You're all doing very well. Wonderful to see a lot of you doing it so well. विनय कैसा लग रहा है?
yes,
कैसा लग रहा है? नहीं
अच्छा टेक्निक को सीख के जाए बच्चे, टेक्निक को सीख के आ रहे हैं और वही पढ़ता है.
Simulation is simulation. You make a fancy one, it doesn't really make idea. You're doing well. You have to see. Sanjay, don't use your fingers to hold the needle. If you have one forceps, that's enough. Make it a habit. Questions on YouTube, yeah?
So how many knots should be applied with the vicryl bowel anastomosis?
One question that has been asked is how many knots with vicryl in bowel anastomosis? The answer is wherever you use vicryl, at least 3 throws, not knot. And I told you 1 knot is equal to 2 throws. And the third one you put so that you can cut the thread short. So the answer is 3 throws, not 3 knots. That's the wrong way to use it. But I know you hear it all the time around you. So 3 throws.
Please show end to side and side to side anastomosis.
You see, the difficulty with all end to side and side to side would be that we don't have the right material. Maybe next time I'll show you. But if you want to see it, my video is on the YouTube on porcine gut. With this, I actually wanted to show you on the glove finally. Why? Because we don't have the, ideal segment to show you end to side. That is very easy if you learn this. No big deal about it. But just that you have a opening on the other side, you will see that in my YouTube video easily. So that's not a challenge. Any other question?
Intestinal anastomosis with suture is preferred.
I told you it's suture. Just now we should told you. I use 30 vicryl. Some people also use PDS because it is absorbable. And I told you the gut needs a tensile strength for not for a long time, maximum 2 weeks. And vicryl would stay for 3 weeks. So that's fine. You can also use monocryl. It's very good. Because the needle is good, especially with monocryl, the needle is good. That's my interest. Any other question?
Which technique is more effective, only continuous or continuous with locking? This is regarding abdominal wall closure.
Continuous with locking is not used. I've already shown you. And it is continuous. Mass closure is based on the modified Smith-Jones technique. There are many people who like to put square, they put in the form of a square, making squares. But this is the technique that I think we should learn. It is based on the logic of the Jenkins theory. So unless you make it continuous without locking, you won't get that spring coil effect.
There is a request for demonstrating subcutaneous suturing technique.
Subcuticular.
Yes, subcutaneous.
Oh, I'll show you. At the end, remind me. Subcuticular, I'll show you because that is required. So, Kriti, remind me at the end. And regarding the end to side, I will see if I can arrange for a tube somewhere, although it will be a challenge now. But maybe next time.
There is a request. Can we fix the needle by using index finger and thumb on the needle holder?
Yeah, you can hold anyway. But classical grip is, if you're watching me on screen, I use this. It's like holding like a pistol. But this is a conventional grip, just about distal to the terminal interphalangeal joint of the ring finger, thumb, and you use the index finger to guide it, backward and forward, right? And this palm grip is when you hold it in the palm. Otherwise, you can, on YouTube, you can see my video on instruments. So I've shown, especially in a skill course. I demonstrate the use. With this, the grip, I have an advantage. I can keep rotating like this. So I can go either way, this way or this way. You will see that in vascular, I'll do the same. This is okay now. This is the grip, palm grip. I like this grip more because I have an advantage of going back to the same. And if you notice, I rotate it here rather than anywhere else. Any other question? All those who have done it can raise they can indicate so that they can be checked. There is a system of raising hand, and Priti will have a look at your picture. You have in Zoom, there is a provision of putting, you can click on the hand. Tendon would be good for Castler stitch. Oh, very good. Where you full thickness, then reverse, which will take the mucosa in. Full thickness, reverse. You're out. Full thickness, reverse. Full thickness, reverse. Full thickness, reverse. Reverse. The problem is it will cause ischemia. So a lot of people now prefer to use simple techniques for bowel because bowel heals by itself. Sutures have only one role, that is the invert. That's why the two-layer technique, when you take full thickness and second seromuscular, so it will go in. Basically, the whole idea is invert. And these are the three layers, serosa, muscle, and mucosa. If I can avoid it directly, I don't need anything else. So there are occasions when I still use two layers, but especially in the bowel, which is smaller, pediatric age group, you should use extra mucosa. It has been shown to have better results.
So which one is safer for training?
The safest for training is extra mucosa. But put it as close as possible. And it should be watertight at least. But the question is very wise because if you don't negotiate mucosa, then you're losing the advantage of either. In that case, it's easier to do two layers. Just put one complete layer, seromuscular, you're done. Psychologically as well as otherwise, when you at least not allowed the pouting of mucosa. Because when mucosa pouts, it sloughs out and leaves a hole. Or it connects to the rest of the organs by adhesions. So mucosa has to go in. That's the rule. That's the basic. I hope you have done your anastomosis. If you have done it, please demonstrate. And then we'll move to vascular anastomosis. Please show it. Yes, all of you. Put your camera on your anastomosis. Your names are captured automatically. We are taking pictures. This is a very important part of the workshop. Ritika Mittal, Ram Kumar,
even Sanjay
Divya,
Raj.
Sanjay Raj. You've done it very well.
Meghna also.
Meghna, very nicely done.
They can do a leak test also.
If you want to do leak test, put water in one corner and see that it doesn't leak. Clamp on both the sides. That's wonderful, but keep it for the end. You can do leak test later on. I don't want you to be leaking around at this point of time. I'll get wet. Kritika Malik, you still doing it? Okay. All right, we have 4 more minutes to wind up. Take your time, finish in 4 minutes.
So this is also for 2-layer homogeneous would be
Vessel, yeah. Tube in a tube. Tube in a tube. Even this one larger size, put them together, stick them together. Do you have vascular clamps? Bulldog है ना? कौन सा वाला? यहाँ पर है। vascular के साथ ही बनाते किसी भी। One more minute to go. Yes. Ritika.
so this is actually कुछ extra intimal layer तो रहता नहीं
हाँ. Just have to teach that there should be no dissection happening. If you don't hitch up the intima, blood will go through it. And the intimal flap can block the anastomosis. There are a few tricks. I think we can now close it. Dr. Sukriti, you should check all the... Done? Sanjay, Raj, we can only see you. Show us your anastomosis. Yes. That's very nicely done. Beautifully done. Can you focus on that rather than you with the camera on your anastomosis? I want others to see too. Yes, that's better. All right. So we will close it here and we move on to the vascular anastomosis, which is what I promised you. If you know the anastomosis, closing an opening or a hole will not be a challenge at all, and I'll be using the iPad. So we'll shift it. Now, please stop it. There are a couple of things which are important. We are doing the vascular anastomosis. Like I mentioned when we were doing the bowel anastomosis, we evert, don't invert. Next, you must always understand that there is a downstream and an upstream in a vessel. So the blood is flowing like this. This is downstream, this is upstream. I hope you can see there's a little lag there. So there is a downstream, the blood is flowing like this. And this is downstream, this is upstream. So the flow of the blood is like this. So you should always make it a point that intima, which is the inner layer that I'm drawing, you know the layers. Media and intima. Media is in between. Intima. This should not be allowed to hang. So we will have to hitch it up. So our bite should go like this. If we go the other way around, the chances of opened retina will allow for dissection. I hope you understood. If you didn't, I'm repeating. This is the intima, and I'll do it again. Let me cut it into two parts. Media and external, media and external. And the green is intima, just to demonstrate. I have the red here, green here. Green here, red here. Just for demonstration. These are two ends. Now, if the blood is flowing like this, there is a risk that the blood can enter into this layer and produce, under the intima, and produce dissection. This is one thing you need to avoid. In addition to that, there can be a retinal flap, intimal flap that can hang and block the anesthesia. It may keep on hanging free. This can become a main picture. No, okay.
Which one, sir?
No, that's it.
This one?
Let's just stick to it, otherwise this also goes.
So ये हो जाएगा.
I can leave. You know. Now, therefore, what do I do? Can we? That's okay. No, I'm saying don't mess it. Exactly. Now, therefore, I'm sorry about that. My bite should go like this, and I should hitch it up. The intima should be hitched up with each bite. Hitched up. Hitched up. So what it does is, it's a hanging patch which should be hitched up. This is a hanging patch here, which hand is which, I don't know. So this hand is this, okay. It should be hitched up. So what that will do, this is intima. If I allow it to hang, if I go the other way around, it's likely that I will be going the wrong way. And this can allow it the flap of intima to hang, which is what I must avoid. So what will I do? I'll take a bite inside out here. So what do? I hitch the intima up. And that will be possible if I take the bite from the opposite side. Anyway, so showing you again. So that is the significance of upstream. This is where the blood is coming from. The second important thing is, when you're using the clamps, we need to use clamps because it's important. We should make sure that we release the distal clamp first whenever we are finished with our job. Sorry. The clamp here, it's the bulldog clamp, vascular clamp, which we can't show you here, unfortunately. Again, you can watch my videos. Now, I'll apply them and I'll take, as I'm repeating, complete full thickness bite, but my bite would start from here rather than from here. That's what I wanted to say. Because downstream, there's a risk of the river flowing under the intima and causing the detachment of intima and causing the, the dissection. We call it the dissection, the intimal dissection, which can hang and cause damage. I hope that is clear. If it's not clear, you will understand as I do it. So that's the second thing which you need to understand. The third thing, if I have two ends of the vessel like this, you must have seen this in many videos, and that's a mistake, that we just do that end to end. It is producing, if you do that, you will have the anastomosis here, right? It is likely to produce a stenosis due to sutures because the sutures are lying in one axis. Therefore, the smarter way to do it is make a cut which is oblique, and then you have an oblique and a healing. So that allows, this stenosis won't happen. Why? Because we'll have an axis which is oblique. So the sutures don't overlap. There's a healthy part here, there's a healthy part here. These are the two things you need to understand. Is that clear to you, Dr. Vivek? Super clear? If you can understand here, I think they will understand there. That's what I'm asking. So what that does is, this is my suture line. If I'd done end to end, that would be my suture line. So this is likely to produce the stenosis, which won't happen. So that's the other thing you need to learn. Coming to what do I use for closing it, we need vascular sutures, which are obviously very tiny, and you need to be familiar with them. And a lot of people use corneal loops or operating microscope or whatever to magnify the sutures so that they're visible. And it's a good practice, something that Sukti has already done. We normally put a wrapper underneath, which is a white paper, so that the sutures which are blue are visible. Otherwise, you can't see the suture. We use the wrapper of a suture material. So what do we do here? Now we have the two ends, and you will do it today. So that's why you just have two tubes. Don't have to worry about it. This again you can do with a glove or any tube. Cut them obliquely. And our sutures would be 5-0 proline. And they usually have, vascular sutures have needle at both the ends. I'll show you that. And you don't have to cut the needle, which is a mistake a lot of people do. We take a bite from this corner, outside in, and we come out. And you can hold it as a stay. And then from here, we do the same thing, outside in. Remember, one more thing, which is a trick. Don't have too many knots at the corner. So what do? We start from this end, tie it, and we take a couple of posterior sutures. You can do anterior and flip it, but it's not possible in vessels like aorta or bigger vessels because you can't just turn them over. It's not possible to turn them over. So don't do it like Bowel. Sometimes you watch that. So we'll do the posterior layer first. We'll put maybe 2 or 3 and leave it here. Then we'll start from the other side, come close to the end, not in the center. And we tie it here because we don't want knots at the corner, which is also slightly different. Once we have done it, Then you keep coming to the end and you come out from any corner and then do the entire layer, come back here and tie it. That's the way it is done. I hope that's clear. Now, that's the other thing. And then what do we do? Just when we reach the corner, we try to, when we reach the corner, we don't tie it, we leave some space, and now we remove the distal clamp first. Why distal? Because the blood will fill back, but there is no pressure in it. If you release the proximal, it will disrupt your anastomosis and cause bleeding. So that's another blunder a lot of people make. You don't remove the proximal clamp, remove the distal clamp or downstream clamp. Let's use that term, that will be easier. So downstream. So a couple of things about upstream and downstream. You take a bite from upstream down and hitch up the downstream so that you have the intima hitched up each time. So this will, each time we take a bite, intima is hitched up. Intima goes up and like fixing something on the roof so that the wind doesn't go and create that space and it falls down. Similarly, at the end, don't allow the intima to hang because that can sometimes cause block, even if you're using a PTFE graft or whatever. So I'll consider a situation where we have lost a segment or we got end and end to end. Closing and opening is very easy. You have an opening, start from one corner like you're doing for the anastomosis and then close it, and before you go to the end, let the distal clamp be released so that blood fills in and the air also leaks out because you don't want air embolism. If you release the proximal clamp, the blood is flowing like this, it will disturb, it will cause bleeding. That's what you need to see. I hope that is clear. Anybody with a doubt can raise his hand and I can see nobody there now.
Group mode.
Gallery. Now I want to know whether you understood with thumbs up. Good. Anybody who has not understood still has time. I can't see, but you can all see and let me know. And I'll switch on to, we'll get the screen off. And I'll show you. All clear? Ritika Mittal, have you understood? Good. That's the vessel and a red looking. So imagine these are the clamps. We don't have the vascular clamps. Okay, these are the vascular clamps. You'll have to imagine. So this is just for imagination. And I'm going to give you two ends of it. So I won't do the mistake of suturing them end to end, which is what I just now taught you. You should not do. You bevel it rightly. Recording is stopped.
Can you please restart the recording?
Just ask.
Record on this computer.
Yeah.
Record to the cloud.
Choose the
Yeah, can you restart the recording? Start. Yeah, start.
Now you can actually see that I have beveled it. And I'll do the same on the other side. And keep it sharp. These are the two ends. And now I'm going to use the suture that I mentioned to you. These are the vascular sutures. You can do with a glove and use bigger sutures. The wrapper. If they're not visible, do let me know. Don't tell me at the end because they're very tiny. I'm able to see. Outside where they give it. Yeah, that's where they keep getting ultraviolet rays. Now you can see I'm getting the suture out of the pack. There are 2 needles. One here, one here. And these are the 2 needles. You can see they are at each end. We use rubber shots, which I could not show you today. Rubber shots are prepared by loading. I'll just give you an example maybe with this. Suppose this was a short tube by putting it on one limb. You can put 2, feeding tubes or whatever and cut it, and that becomes a rubber shot. It becomes less crushing. So that's a rubber shot. That is for the sutures. Because the suture is too tiny, and it's a monofilament. The suture can actually fracture. So we need to keep a track of the thread, and usually it requires good light, a wet hand, and importantly, a good sight. Now what do? These are the 2 parts, the bevel that I've removed. I can enter from one corner, come out of the other. This is one place where you'll have to handle the thread. It's too tiny for instruments. The instruments can actually crush the thread. So I've got it in my hand, and this is one place where we use initially 3 granny knots so that it sits in nicely. 1, 2, that's in the blue camera cover, the handycam. 3. They are putting all granny knots, no crossing, because I want it to slip. Now what do I do next is, I'll put a proper reef knot. That takes care of it, so that it is secured. Granny was when I was using the same middle finger and sliding it down. That did the job for me, for letting it slip in nicely. Now I've got a needle with me. Most of us like to do the posterior layer first. The reason being, in all big vessels, it's very difficult to flip and go. And can you just assist me, Dr. Wait, hold the thread. Now the posterior layer, very easily, and we keep a distance of 3 millimeters. I'm repeating that. That's 3 means 3. Cannot be big, and not too many knots inside. See clearly. Now, for those who want to see what is a corneal loop, I brought out my corneal loop just to demonstrate, and I'll use it. It will make it possible for me to, yes, see clearly. You can do without it, but I need a good light. That's why. Now the point is, if you have, can you make the light focus? Yeah. Now, and if you keep the thread pulled, it becomes easier. It's getting a little defocus frequently. The parallax was gone, but again, keep some distance because there you don't go that close. Huh?
Yes.
Can you hold it? So what you can do is I'll use it after removing the parallax. I just needed the light. That's simple. 3 millimeters away, and outside in, this is a downstream, so that's what I was trying to tell you. This is a posterior layer. In some of the training videos, you may see that they do the big role of assistant in this. The thread has to be kept in the direction of the knot so that there is, yeah. If it is visible to you, let me know. If it is not, make sure that you don't take both the layers, which can happen. So far we are fine. We put in the forceps, and actually we use what is called the Baker's forceps, which we used to have. We used to have it. Okay. I would have preferred the Baker's forceps, but that's okay. Use whichever is available. Look at the challenges. Don't get perturbed. See, we are just moving 3 millimeters away. He has to zoom, you have to see, everything is difficult, but you are. when you do it on the glove, you might argue what is the difference between this and the bowel. In a glove, there is no difference. It will be when you are doing it on a vessel. A few finer points which are necessary to be understood. I'm just trying to fix it so that we are able to stable one, because vessel is usually not so freely mobile. So I'm taking the posterior layer, which is not what I did with the bowel. 3 millimeters away. I've reached the end. Usually I'll put a space suture at both the ends, which I told you, and I'll go from both the sides. It's not, this is one more way of doing it. A lot of people like to just carry on this way. The idea is to stick to the principles and make it a waterproof. Airproof is very difficult, but waterproof certainly. Lighting did help. Yeah, that's better if I'm focusing where I needed it. Challenge for you to win. So what have I done? I have not locked, and I won't let it be locked. That's what I need to be careful about. Can you leave it? So that takes care of the posterior layer, hold it tight, and in this axis vertically, in the axis of the anastomosis. Now, because it's beveled, so it may look a little cockeyed, but it is not. Again, my video on the YouTube showed the cosine. Aorta. Now, it is a much better way to do it. Sometimes the needle is too good for the needle holder. Nobody's business. I've come to the anterior layer now, and I'll go maybe a couple of sutures, and then I'll come from the other side. There you are. Now I'll start from one stay that I'd kept with the needle. That was the purpose of that stay. I realized that there was a corner which was so I'll get that. Now you can see the downstream is the retina is, intima is getting hitched up each time. I'll again show you what I'm saying. I'm taking full thickness, and I should do that individually so that I'm not doing any mistake. See that? So this is tacking the intima up. That will prevent any dissection, as I said. So when the blood flows, it will not be spreading or splitting the intima, which can cause actually dissection. Now I'll go where I stopped. And I'll go beyond. previous bite. The rest is simple. I have the two ends with me. And I'll do now, once again, please zoom out a little so that I can show them the knot. That's it. You may wonder, what am I doing? I told you to take reef knots each time. Now this has got a reason to be putting this is a granny, if somebody wants to know. I don't care which end is where, which is what somebody was asking. I just put middle finger throw. 1, 2, I put 3 grannies. After 3 grannies, I do the reverse. I'll put a proper index finger, cross, middle finger, cross, index finger, index finger, and cross. I forgot something. I hope you remembered. I was more struggling with the stuff, so releasing the clamp, which I could have done before the last bite, which I was telling you constantly it's important. So what I would have done before I close the last part of it was to release this downstream, the downstream flow. So I would have released this clamp first. What that would do is the blood will flow back and air will come out of here. So there is no air. And then I would release this one. Clear? After I've released, because that takes care of any air which is trapped. And then I'll put this knot that you're looking. Always keep it at least 2 centimeters long. It tends to have a memory. This is a monofilament. And you can see that it is no oblique anastomosis. So I'm using this kind of a tube for the first time. It's not too bad. You can do it on your glove. Before I actually close it, I must release the the distal clamp first. Distal clamp I release because the reverse flow will happen. It will make it completely air free. Then I'll tie my knot and release the proximal one. Now this is basically for your understanding. If I was to repair opening in the, I won't waste another one. So if you have to do an arterotomy, it is usually done using 11 number blade. Now, whichever number we have, 15 have. Now, I'll use another one so that you don't get confused. I don't want to give you anything. I'm just showing you arterotomy. How do you close it? Because that also is important. Vinay has learned the correct technique. Now we are here. I'm showing you the making of an arterotomy. How do we make it? Transverse. Usually, give it a puncture by putting the blade at 45 degree. I hope the camera can show that. That's showing. And we won't take the posterior. See that? That's the opening I made. I can extend it usually transversely. So this is less stenosis. And for that, I can use the pot scissors, which we have. Where did I make the opening? Be precise. There. You can understand that's the purpose of pot scissors. It would not take the posterior layer. It will just take the anterior layer. Now I'm showing you the closure of an artery. So that is, if you cannot do the anastomosis, at least do this. Do we have another suture? This is the only one. We have another vascular suture to do this, and you can actually see this. Principle is the same. I'll quickly show you, then you can do it. You'll be left only with the tendon at the end, so you're learning some advanced stuff. Don't be disappointed if you could not procure something like a vessel, which is easy otherwise. You can just pick up any two tubes, cut your stethoscope into two, the one which you're not using. This is one end, this is the other end, and you can see that's the two ends of the suture. Never do that mistake of cutting and using it. Can you focus here, please? So again, the principle is the same. This is a downstream flow. This is the flow. So I will have to take the bite up this side, lower side. This is downstream, this is upstream. So zoom out a little bit. Downstream. So what I have to do is, I'll have to go outside in here, but here I have to each time tack the intima up. That's what I was trying to say. Now we are ready, and we need to take care of the suture and the needle. I'll start from this corner. It's slightly tricky. So look what I'm doing now. Inside out. I'm tacking the intima. Not even at the corner I'll take a chance. Intima is fixed. I can take further to the corner. Sorry. That's my corner. It is hitched. And what do I do with the other needle? Can I have the other end? I'll do the same on the other side. So I have both the needles out. Don't allow them. Now I'm at the corner, same principle. Granny, 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 proper, leaf. Leaf. Even if you are not able to do it with whatever you have, learn the principles. Middle, index. And now I'll hold this needle in an artery forceps so that it doesn't come in my way. I'll use it subsequently for a second layer. This is kept away, and now I have only one way to go. Let's hold the thread. This thread. I hope you can zoom it now. Come on, dear. Very good to use. Got the Bakey here, but then we don't have it. Hold the complete layer and 3 millimeters away. Same principle. You practice this rather than anastomosis. Good. Keep it taut. You are fine with this. Managing threat. You're trying to both. Put the forceps inside, you can see it better. Take one layer at a time. I'm at the corner, I'll not tighten it. Okay. Now I'll not tighten it. Now I'll demonstrate what I was trying to tell you. I had a clamp distally and I had a clamp proximally. For those who did not follow, some of you were asking, so I still have open space and I've not tightened it. The forceps will help me see the corner. See that? I'm still open. Right? So what do I do now? I will take away the distal clamp. So now see, even otherwise the air fills in, the blood fills in, everything gets cleared off. And when everything has got cleared off, I'll pull it. And this was to avoid air embolism. Can you hold it back, please? Limitations of whatever we have, but we're trying to show you. This is the corner. I'm not locking. Now there you are. The proximal clamp is still on. And I'll show you when do we remove it. And there is no locking. I don't believe in any locking here. It causes ischemia. Just keep it there. Now what do? I would release. Please watch it carefully. This will be held like this. I'll release it. And I'll see if there is any leak happening, which can happen. You are not perfect. Now there was a second layer to go, which can be so easily put now, which goes in between wherever the space was remaining. Now that thread is, I can hold it in my hand, keep it taut. Now I go over and over again and make sure. Now you cannot see the wall like you did earlier. The assistant would follow the thread. Very good. Now the light is there. Hold this side now. So what did I do? I went in between all the spaces where there was a this thing is falling, and I'll try and go beyond the last tray that was kept. And the two now can be. Can you release it? Easy again. Granny. Correct to settle down. Now you can cut this thread. Let me try. Second one. And the third is granny. Granny is where you don't cross. And actually you're putting the middle finger, which is what somebody was asking. Now this is proper index finger and need to cross each time. Index finger throw and the middle finger throw. The index finger throw. Finally, that's about 6 to 7 rows and cutting it a little longish. That's closing it. Would have been better than this. We can do a better job with a smaller lip. Okay. Now, that's the closure of an outcome. Now you can start doing it. I know it's a little bit of a challenge. You can make an opening in the glove and do it, or use a tube. Can you show on the gallery view what all you are using? I think that's brilliant. Somebody has got a tube. A lot of you have got a tube. Very nice. They managed it. And that's the anastomosis. Hmm? Oh, you got a similar tube. In fact, you got a better one. Oh, that's me with it. That's not there.
Then she has got one.
Oh,
Ritika Mittal.
Ritika, you've got a brilliant tube, and that's the anastomosis, which will be at an angle, so oblique, so it will not be causing stenosis. Please do it in next 15 minutes. It has to be better. Vivek, there are some challenges, but it can be done.
Yeah.
Especially for the vessel.
Yes, consistency is not very good. I think it should be of different material.
Material should be totally different.
Yes.
Very thin tube.
It's
Moving with suture. In fact, the suture is thicker than the tube.
it's not the right material.
No, you should. They loved it. I think they
Maybe some cloth material would be.
Hmm. Now, I think you're all doing fine. If you could show as soon as you've done. Camera or camera? It's camera here. Nice. You more this time. Once again, I've used the iPad and show them the. Bypass normal injection needles. नहीं बट देख नहीं देखो टेंडन में तो यूज होती है ना और समझ नहीं डॉक्टर सीधी देख रही थी I think a lot of you have already done, so you can demonstrate, show it with the camera so that she can take a note of it. I know it's a bit of a challenge, but a lot of you are doing very well. Any questions on the YouTube? Yeah, Dr. Vivek. Also in the chat box, if there are any questions, take a note of it. It's your camera.
Yes, there are a couple of questions.
Meanwhile, there are some questions in the YouTube group which have come to me. The first one is, should we apply Lambert sutures over the single-layered extramucosal bowel anastomosis? The answer is no, because if we were to do that, we wouldn't be doing extramucosal. The purpose of Lamberting is to invert the bowel. So Lamberting is done when you put one complete full thickness layer and then you put seromuscular to bury it. That's Lamberting. So you don't need Lamberting suture after this, because then you will narrow down the bowel. It's not a good thing to do. Next.
There is a question for vascular suturing, why 2 needles?
Why 2 needles? Very good question. Because we need to start from both the sides separately. And if you use the same needle and go around, the chances are that, the advantage of doing with 2 needles is you can take hitching sutures on both the sides, so that will hitch the intima to the rest of the wall, both sides. So the stays can take care of the corners, and then you can come from one side, from the other side, and you don't need to put the knots in the corner. If you use one suture, then you'll have to put the knot in the corner. So you'll not put too many knots in the corner. One knot is all right, but you come back. Like in bowel, you can come back and you have to put the knot again in the corner. So it is therefore advantageous. Even for tendon, you can use 2 needles. That's a very useful thing. Although we don't need it for the tendon, but otherwise. Any other question?
Yes, sir, there is a question. Can you please show the difference between granny and weak using a thicker suture or with the cord itself?
Can I have the knotting pad?
Knotting both.
I'll show you after the tendon. When I've done the tendon, I'll show you this. But because they're just now doing, we'll do that after the entire thing is done. I'll show you granny again. And I'll show you the reef knot, and I'll show you the reason why reef knot is necessary. Again, on an iPad, I'll answer your question. Can I have the iPad after this? So I'll show you the purpose of having 2 needles. Next question.
When we do anastomosis on the vein, how do we check backflow and air when the veins have valves?
In the vein, the backflow would be less, but it's not a challenge in a vein usually. This was an arterial anastomosis. Please try to understand. In vessels, in veins especially, it may not be such a challenge because the flow is on the other side. So you have to understand the downstream is different here. So in the vein also the flow will happen at least in one direction. So the idea is to open up from distal to proximal. When you open up from distal to proximal, then the backstream will happen. The vein will have reverse mechanism. But you would still think about the downstream because the flow in the vein is the opposite. Next question.
Something about the leak test and patency test.
The leak test and patency test is leak test mainly. You push in saline and put clamps on both the sides and you can see it leaking. And for air test, air leak, you don't put saline in it. You have the bowel as it is, emptied bowel, you clamp it, or you put the bowel as it is in a bowl full of saline. So you'll see the bubbles coming. You've seen those people in the earlier days used to fix the punctures of your tires, right? They'll have the tube in water and they can see the bubbles coming. So that's how we test it. Now I'll show you on the iPad now. I think most of you have done it. And those who have done it, please demonstrate their anastomosis and we are moving. We're going to the last part of it, of the workshop, and then I'll answer all the questions. I will show you the granny knot, so don't worry. Now, first of all, I am very keen on answering the question that somebody asked about why I have 2 needles. That's okay. That's fine. Now you have the intima. I'm just making it with red. We didn't have an ideal situation to show you the vascular anastomosis, but we'll cover up for that next time. Now I want the intima to be hitched to the wall. It's taking a while to show up, but I'm trying to show it on the iPad. It will be here. So I want it to go in. So what do I do? If I have 2 needles, with one needle I'll go inside out here, and the other needle I'll go inside out here, which I cannot do if I had only 1 needle. Is that clear? So the thread is here, needles are here. So the needles have come out inside out. And I put a knot here, and then I can use one, and the second one can go over. That's the purpose of having 2. I hope that is clear. Anybody who asked that question? So that is possible only if I have 2 needles. If I had only 1 needle, then I'll have to maybe inside out I can take here, but here again that issue will come. But you can do with 1 needle. It's ideal to have 2 needles to hitch it on both the sides, so that now you can actually hitch both of them. The intima can be hitched up. So there is no what you call as likelihood of the intima hanging. Mind you, when the intimal flap is hanging, it is a very important cause of blockade of anastomosis. It can block. It hangs, so it can block. Now, I think we can move to the tendon now. And what we are going to learn is called the modified Kastler's stitch. Very useful stitch. If you learn it, most tendons you can repair, and don't just suture them when you get a cut wound or a lacerated wound or an incised wound in your internship or otherwise. It needs an expert hand to do it correctly. Now, can we change the background again to Gurukkul? Yeah. So now we will show the Kastler stitch to you. Please pay attention, and because it's some finer points, and I know it's a fag end of the day, but you guys have done very well, so you will earn it. Now, what is it? There is a proximal end of the tendon. Always freshen it. They usually torn badly. It should be sharply cut. This is the distal end. Now, the proximal and the distal end. Remember, the fibers are longitudinally arranged. You have, these are the fibers. So if you put a simple stitch, it's not going to hold because they are longitudinal fibers. You can't take a bite and hope that it will stay into place. So therefore, we take what is called a Kastler stitch, which has two horizontal and two vertical lips. Please pay attention. This is the distal end. This is the proximal. And I'll use a black color to show you. We enter from here and come out anywhere, say about 1.5 to 2 centimeters to the one side of the tendon. To enter again through it absolutely horizontally and come back in the same way that you entered here. The needle is still with me, and I'll enter the other side and come out the same distance on this side and come back in all around, and I will be out here. So there are two sutures that are there, two horizontal and two vertical. Now these we tie with each other, so it gets, it's like a sack being put together, because if you just put sutures across, I'm trying to show you in another axis now, so that your concepts are absolutely clear. This you must know. That's one end of the tendon, that's another. All these are fibers. So if I take a bite like this and like you normally suture things, it's not going to hold. So therefore we need to first put them together as one by using a transverse suture and then going along the longitudinal axis. So I'm again showing you, this is the cut end, distal end, and the red would be the suture. I'll enter from here and come out here, only to go across, come out here, and go back absolutely parallel to where I had entered earlier to reach this point. Then I go through this the same way that I had entered here. Don't forget the first time I entered. And anyone who does this suture good today will get 10 extra marks from my side for being selected as a resident for the scholarship of the American College of Surgeons. I want to see how are you paying attention at the back end of the day. And then I come out here. Same thing I'm repeating here. Okay, and I go back to come out through the same axis. Then I tie them with each other. So what that does is, that will bring the two together like a pack or a sack. This is a modified castless stitch, which you can see very clearly now. That's the tendon. That's the cut end. These are those tendon fibers. And I'll show you what do we do with the epitendon, which is the covering layer which you all know, which is on the surface. It also has a layer of sheath, which is called epitendon. That I'll bring together to smoothen it so that the tendon can glide. This is a castless stitch. I've just drawn it for you. It's a copybook picture. And you can put up. Now, if I can have a gallery view and your thumbs up, then I'll be happy. Because if you have understood this, this is also called a K stitch. And we can get the practical demonstration going. Thumbs up if you have understood. If you're not understood, yes. Who is this? Meghana. Always the first to pick up. Very good. Right. So we are ready with the tendon for you. Great. And I'll show you even here without any trouble. There is a tendon that has been provided to us. It is a silicone tendon. And the patient had a very nice cut, which I'll give. Can we put something underneath? This can go underneath so that we can see the sutures more clearly. I use that for nerve anastomosis, vascular anastomosis. Put a simple wrapper. That's the tendon. Okay, and you will soon be seeing that there can be a little defect or a gap. You can dissect for that. So sharply cut. And I'll try to demonstrate to the best of my ability. Pay attention. That's all we can do. We have limitations. We bow to the limitations or we conquer them. It's up to us. And as my student, you should learn to conquer them. Now, there is one rule which you must understand. Once the needle is been cut, or the tendon has been cut, we need to put two simple needles which can help us pith it. This is used in normal circumstances. These are typical hypodermic needles, no issues. Both sides of the tendon, we can actually fix them. Some people like to keep them loose, but then it does help to keep it when there is no tissue around and fixing it, so that your job is made easier. There you are. Alignment is perfect, and the tendons have got the hypodermic needle on. Now the suture. Same, two needles. Most of these sutures will have two needles, but here I don't need the other needle, so it's very easy. I'll just cut it off and be relieved of the burden. There is a role in vascular anastomosis, no role here. But like you saw, I put it in the kidney tray. That is what you get marked for. Thank you. Now hold the thread because it is likely to get tangled more frequently than the others. Now this is the distal end. What do I do now? I'm going through and coming out from one side. Okay, I'll be happy with a little bit more light. And I've come out on one side. I would have wanted a slightly bigger needle. And hold the thread in this axis, please. It has to be held in the axis of the hand. And now I go across, as I told you. And the assistant has to make sure there's no knot. I've gone across. And we will now go like we entered there, longitudinally. No issue. I have come out. That's perfect. Now I'll enter the other side like I had done earlier. And I'll come out on one side again. Now the transverse one again. And what do I do now? I go longitudinally again. Don't worry about what you have. I need to come out longitudinally. There you are. Perfectly done. Now let's see how far is the needle helping. So I am in the center with two ends. And as I pull it, they are together. Okay. I am pretty fine with this. Here's the short end. Now that's the short end. I'm going to put the index finger. So the line there. Leave it. That's the index finger throw. I'll tighten it first. And then the short end has come towards me. So middle finger throw. Index finger through. I think the camera should be focusing. I'm not able to see it. I'm working here.
Yeah. Focus. Do it. Zoom in.
Are you okay? Yeah.
Yeah.
Okay. You're fine. That's your caster stitch, 50% done.
Yes.
This tendon is going nowhere. If you just take a bite from the edge, it will tear through because it's a longitudinal. It's like a sack full of grass. You can't suture it by putting sutures across. First you have to put transfer sutures, then you put, see I put about 10. That's usually sufficient. No cutting, we'll hold the edge, and now you see what do I do with the remaining thread, please follow it. And I will go and take the epitendon. That's the epitendon which I was marking. And keep going around. So what that does is that smoothens the edge of the tendon, so it can glide. It can glide comfortably on any wound or any bone or any surface, which is the purpose. I'll have to go 360 degree. Therefore, the needle better be good. I have a solution for this.
Yes.
Keep it taut. Can you just keep it fixed?
Fixed.
And board up again.
Tightly holding you.
No, I think you just got to buy some stuff.
पिन भी छोटे हैं एक्चुअली पिन का प्रॉब्लम हो जाएगा.
No problem. You can now see for future.
Yes.
See, I'm going vertically down. You will see at the end a fantastic Kessler stitch. Nobody can tear it then. Hold it. I hope it is coming in the view.
Yes, sir. Visible.
You guys are not allowed to speak, otherwise in my class they all can shout. Not able to see. Now we will nearly be done, and you would have learned a modified Kessler stitch. If you go around telling the whole world, now I know how to fix a tendon, how to fix a vessel. You need to practice more. That's a different story. We all need to. Now there is a trick to it now. I'll again put in a artery forceps. And my assistant should feed me that needle. What do? I'll flip it. And the job becomes easier. I'll give it. Hold it. Hold it down. I flipped over. I'll hold my thread with my hand. Take a very clean bite at the. This is epitendon, which is the sheath covering the tendon, so that it's smooth. Otherwise, it will be a rough surface, and the tendon would not be able to glide smoothly, and the function would suffer. See now, I am there at the end. And invariably, when you're going in circle, cross the stay. Always cross it, so that your strength is not that get locked. They're gone beyond. I've reached the end, and now I can actually lock it, what you're looking for. That gives final strength to it, and I have the two ends with me. Can you remove the artery forceps? And if the camera can zoom, index finger throw, middle. What happened to it?
So you're just taking a phone call.
Can you just zoom it? Index, middle, index, middle, index, and I put 7 throws. We have the lights here. I cut it above. So that's the Kastler stitch. That's your tendon. I'm trying my best. You can't just take it away. That's the tendon. Can you give them a view? You see, this tendon is sutured with a Kastler stitch. It's going nowhere. Complete pressure, pull. So the tendon is repaired. All right. Thumbs up if you can see and you can do it. Okay, others. This is the advanced version of your training workshop today. Can you zoom? Anybody with any doubts at this point regarding this? Because I can draw it again on the iPad and you can have a good idea. Please switch on your cameras, all of you. Ram Kumar, Divya, Vasu. Doesn't matter if you have not done it. I can show you again on the iPad at the end of it and I'll take all your questions. That was the last exercise. So you've done pretty well. Ritika Mittal, show us your tendon repair now. Start doing it. You've not yet done it, no? So don't tell me you already done the Kastler stitch. You did before me. Modified Kastler stitch. I'll show you on a paper here. No point using an iPad because it will disturb the picture. Give me that paper and I'll show it. This is visible. This is come out well on this.
Yes, sir. This is the tissues also.
Suitable. I'm trying my best. Actually.
Now that leaf and difference they asked.
Yeah, I'll show you the subcuticular sutures after this. We first do the Kastler stitch. It's still visible here. The Kastler stitch here is where the mark. Repeating. I entered into this. It came out here. So, like this. And then I went right across. Again entered and came out to the center. It came out of here, came transversely back, again entered and came out in the midline, center. That's what is Kastler stitch. Let me see how many do it. Modified Kastler stitch. I'll show you the subcuticular. So for that I need to cut these sutures out. मोनोक्रिल है ना आपके पास? Vehicle load, जो दे रहे हैं उनको वही
40 है सर मोनोफोरम
40
यस सर
है ना 40 होता तो है ना इंस्ट्रूमेंट्स में तो अगर मिल
यस
जाता हो
16 mm
I'll show you all the granny and other things when you do your work. है ना 40 की needle मुझे तो दिख रही है जीन दिख रही है ये needle अच्छी होती है अच्छी needle तो वही है ये
यस
ये तो नहीं ठीक तो नजर आ सुने ये दिखेगी नहीं इसमें कलर ऐसे दिख नहीं रहा ब्लू कलर वो दे दो वाइट पर कितना पतला इधर वाइट या और क्या
मोनोफिलामेंट इज अ प्रोटीन है शायद हम यूज ठीक है 40 रखा था सर जो यूज
तो भी ये यूज ये है ना all the questions together to wait and of course because you can just answer in one go.
Got disconnected.
तो चलेगा vascular anastomosis क्या लिखा
In vascular anastomosis, proximal embed should be outside in and distal end should be inside out on intersection of empty.
last one please repeat granny मैंने नोट बता दूंगा ग्रैनी जानने इसमें सिर्फ है तो करना another 5 minutes maybe. It's just one stitch you have to put. So They may not be able to put it just now, but they will know there's a stitch like that. They will suture it like that. It's not in one go that they will move over medical transplant. You need to very stitch for them. That it's really a very enter, go across, enter, go across, come across, go come out, enter. Rest stitches go on.
It's very fragile tissue. If you not do carefulness, they will pull apart.
Tendon can be a challenge. They may get it in a feeling. By the time they refer, for 6-8 hours, this tendon is not worth repairing, and the person has lost the function. These are important parts. You'll be surprised I use it even from Bowel. You consider the same. Nerve has many bundles inside. The concept is though two sacs pull off goes up. You have to stitch them together. How would you do it? First you transfer to make them one. Then the same with the crack is that. You need to be concept is that. For the vessel, the concept is intima should go. After the dundee. Very often you dundee anastomosis, but the blood supply is not restored. So the intima friction getting blood आता रहता है इसे नदी के किनारे में वो छिलते चले जाते हैं और छिलते चले जाते हैं इंटिमा फ्रिक्शन जाती है इंटिमा में काफी खुल जाती है तो पर्दे की तरफ गिर जाती है प्लॉट बन जाता है they will to register all of them are going to be vascular. This is for the basic understanding of it. Which clamp to use. Another mistake we have seen. We done the repair the proximal one. We remove the proximal clamp and the whole thing is flowing. Even without casting the river. We need the distal one to the back flow. Why feel we can get the flow? It's a diameter on the release for it. It's perfect. There is a bell there. The condition happens to diameter close to the water fills back. All the loopholes are checked. Then I hope it is done. Can you show it? Sukriti, can you record quickly so that we move on to the queries and questions? Please demonstrate your modified Kastler stitch. Okay, focus your camera on the who is this? Sanjay. Oh, very well done. This is
Yasin.
hmm?
Yasin.
Yasin. Very nice. This looks to be the best of the lot just now.
Sanjay is also.
Sanjay Raj. Yes. You use polythene, but that material which Yasin has used is going to show up. Ritika? Don't worry. I'm not rushing you. All those who have done it can show it. Some people have actually fallen asleep, maybe. Ram Kumar, I want to see your face. Dr. Ram Kumar. Dr. Ram Kumar is showing now. glad you're awake. This is Sanjay. Sanjay, you've done all right. Don't worry. Rishikesh. Yasin, yours is okay. Meghna. She's still doing it, no problem. Kavya. Very good. Very nice the way you used it. It's a very good castless, modified castless stitch. Kavya. You see, you can clearly see the transverse and the longitudinal sutures. You understand?
Chest tube or something like that.
You've used a tube, chest tube or something. Brilliant. Very good, Kavya.
Transparent and smooth.
So since it is transparent, you're giving me an idea. We'll use this next time. I've taken picture of this. Beautifully done, Kavya. Show me your face, Kavya. Beautifully done. Excellent job. Very well done. You understood the stitch. And I'm so glad. That is a good idea to use a tube which is transparent. You can actually see the stitch clearly. I think we'll move on to some of the queries now, which were asked about the granny knot. And I think you all understood the modified caster stitch very well. Credit to you. Now, we are back to some of the questions. With that, we actually would be able to conclude. But you understand these queries. They are for the benefit of each one of you. Now, can you stop and pay attention, please? Please stop and pay attention. Or maybe a minute. Okay, you have a minute. 1 minute only, please. My phone is full of their pictures. They've all been sending.
What's up, bro?
You see the tomatoes?
Wow, awesome.
Tomato suture.
They have got some house stuff.
Tomato. Cotton. मुझे बनवा लो. I'm later ये बना देंगे मुझे. Another tomato. See how beautifully sutured.
Suture आए सारे.
You'll never forget this thing. See? Beautiful. See? Record करके रखा है उसको कर जा रहा है. It's a good one. See now? Beautifully done. Brilliant. All right. So please pay attention to the queries that were asked. One was about granny knot. Please pay attention. How do I know you're all paying attention? Otherwise, I'll be waiting. Give me a thumbs up, all of you. And let's first get the answers. You can keep on doing that. I'll give you time to practice. Okay, so this is it. The pad that you saw in the beginning. And now just focus on what I'm saying, then you practice. Can you ask them to all focus on the knots now? Can you ask them all to focus on the knot now so I can do it once for all? Can you ask the organizers to tell them somehow, or you can tell them?
We now have the granny's knot. And
No, I'm just going to demonstrate the knots again quickly, the granny. So pay attention. I'm still seeing people working.
please stop doing if you're still continuing. Focus on the screen now.
All right, the short end is away, the long end is towards me. I am supposed to hold the thread between the ring finger and the thumb and use my index finger to draw it out like a figure of 4. Can you focus here and zoom, please? Draw it out with my, fish it out with my index finger, not leaving the thread, securing with the middle finger and crossing over. That's a classical first throw of a reef knot. And then I'll hold the short end like a dart, wrap it around my 3 fingers, bring the other one right across, hold on to the intersection, use middle finger and cross back. Can you zoom, please? Zoom, please. So that's a classical reef knot. Now just see what I do next. Now zoom out. Now I don't care which end is where, and I'll hold it like anyway, and I'll do what some of you were asking. See what is happening. I'll use a purple thread so that you're able to see better. I'm not doing this now. I'm putting the middle finger through when I should have put index finger through. You can see that the thread is already crossed, and it will cause bowstring injury. It will rub against each other and cut it. Secondly, what do? I put one throw. I am not crossed. I put another. I still don't cross. I put another, and I still don't cross. I can put as many. Now zoom here, please. Right, I may put 10, 15, 20, but what have I done? This thread is the same as this thread, which is same as this thread. Now, no, you're not paying attention, then you'll ask me the same question. That is very, very disturbing. Single straight thread, and I've just got twisted loops around it. I can, first of all, the problem is I've already crossed even without a throw. And then I've got merely the twisted loops around the single thread. I can take it off any time when the knot is over. That's a granny knot. That's why I didn't want you to practice. Don't practice it, please. It's not for practicing. Don't do it. It is also called a slip knot. That is, I don't cross. If I don't cross, it will be a granny. I don't cross now. I stay there. I put another index finger also. I don't cross. I can make it slip down. Well, it's not a knot. But then what do? I can put short end is towards me now. I put a proper throw and index. So I secure a granny. So when I was saying I'll put a granny, it was in a vascular scenario because I wanted the thread to or not to slip down. Also, when you're tying at depth sometimes, it can be beneficial because it is easier to throw it down. This is the tying at depth. I hope you have understood what is granny knot. Granny term has come from the grannies when they were knitting. So when they're knitting, you must have seen that they keep putting those threads 1, 2, 3, 4, 5, 6, and they keep pushing on that when they're knitting a sweater, right? And at the end of it, they put a proper reef knot. If they don't, and you have a cardigan, you're wearing it, and there's a loose end, I can pull it and you'll be without it very soon. Because you're not crossed anytime. So sometimes you use the granny knot. So I don't know why were you so keen on knowing about it. Granny knot is not something that you practice regularly. Don't remember it. As students, don't bother to even learn it. I just showed you. So granny knot actually happens when you don't learn the right way. The right way is this, which you must practice the whole day. Every time when you're sitting, do this. Reef knot. Basic knot, that is what you should remember. Don't try to remember the granny. Granny is a wrong thing to do. How is granny put? See, I'm holding it like I was holding like this earlier and using an index to make it out of 4, take the throw through and then cross. If I don't cross, it's a granny. I keep on putting as many as you want, 20, 30, but they're all useless. Nothing has happened. Actually, I've just got to twist it. This thread is straight and I can just undo this knot in no time. So that is granny knot. I hope you have understood. So that question is answered. And don't learn it. It was just to teach you that if you put granny, it slips down better. Even there, you can do without granny and do without granny. See, I have undone the knot. Now you wanted to see the subcuticular sutures, which I'll show you now. It's not subcuticular, it's a cuticular suture. It's a misnomer. Because you go through the cuticle, there's nothing like subcuticular suture. I kept the needle here. I kept it here. Now you preferably use monocryl or any good suture. I have monocryl here, but you can't see the thread because it will be not be visible. This is not the one. There is one here. You can use 201. Okay, I'll show you with whatever I. Now I'll need some light so that they can see. You can show that light. And I'm using a very, very fine material for this. And what you can do is pay attention. You can use an absorbable suture or a non-absorbable suture. It's optional. If you're using non-absorbable, you'll have to put a suture knot somewhere. Otherwise, this is the end. And I can enter from anywhere. I've entered from one corner. And I'll apply artery forceps at the corner. I'll do that. Please follow the thread. That's the key. Now what do I do? If you can see it in the camera, I'll just be taking the corner. For surgical anyway. And I'm taking just the cuticle if you watch it. I don't take the subcutaneous tissue. That's a cuticle. And I've taken the bite from the opposite side. And now I'll enter where I came out on the other side. That is, I'll enter exactly where I came out. See, I've come out here and not pull it, because that is easier for me. You can see that. I'll just come out on the other side, exactly where. And when I'll enter on the other side, exactly where I came out. See, I came out here. So what is just opposite? I'll enter here. And I'll come out on the other side, exactly. I'll enter on the other side, exactly where I came. So it's easier if I continue. You can see that needle is rotating in my needle holder. The needle is too good for the needle. I'll continue to take bites, exactly opposite. you can see that the tissue is coming together without any challenge of being visible. Just take the typical. The trick is simple, just match it to the other side. This much is already closed. I don't know what is visible in the camera. कुछ दिख तो रहा नहीं, zoom करो, focus करो, दिखाना पड़ेगा. Can you focus it now? Visible now? But I'm looking down, so please. Dr. Vivek, get some instruments now. They're all done. I'm not holding. I'm managing. Needle is going places. Yes. Yes. No, no. ये needle holder जना जना वापस गया. Not holding. You should not go through. I'm just entering opposite side where I've come out. That's not so difficult. Very easy to do. You use very, very fine sutures and a good instrument. That's how faster than usual. We are almost there, and I'll show you at the end what do we do. Well, it's very simple. You just get through the cuticle. Dr. Vivek, please take out any questions.
Yes, sir. We have two questions.
So once I'm just done, then this will be the last exercise. No. I made a big incision, so it's taking a little while longer. But we just there. I accommodated a torn piece. I enjoy doing it with a monocryl. It's a very, very sharp and black needle. And the suture is very good. I use it frequently for. Now what do I do? I've come out at the end. This is one way of doing it. I come far away. This is an important step. The suture is all done. You can see. I think we keep it in the focus. Vinay is tired now. Totally out of focus all the time. Everybody could dig it. Now we go and hold up. Now I have entered here. See, the needle is moving all over the place. So I'll through the same opening I'll go far. Actually, I'm going to confuse the needle and the thread. So through the same opening, I entered here and I'll take one more exit and I'll leave it there. Now I'll enter exactly where I came out. That Z will make the thread disappear in the tissue and it will retain its tension. Since it's absorbable, I don't need to remove it. That's the end of the suture. Here you had an option to make a knot and I put a knot on itself so that it won't slip off, at least in the initial part. Later on, we don't know. It will be absorbed by the time. And you can tie on itself. It won't go anywhere now. That's your closure. See that? I'm trying to spread it. You can't see the incision. All clear? Now, please focus on this so that they are able to see it clearly. Let's have your questions now. This is a subcuticular suture. If you want to do it, take 5 minutes and do it. I'll wait for that and then I'll take your questions. So we'll check for that also. What are the questions, please?
Third, which suture for tendon repair?
आपके निकालने में जो इंस्ट्रूमेंट का आपने निकालना
You keep them too far. I've seen some of the pictures. The distance between the sutures should not be too far. Then it will be crumpled up. It won't be the same. I told you, where you come out from one end, you enter on the other side. Just keep going absolutely in the same way. Now, I have a question from all of you. If you can write in the chat box. First question. Are you all listening? The first question that I would want you to answer in the chat box, all of you. Did you enjoy it? Did you have fun? Glad, but I want all of you to write. And then continue doing your subcritical work. I don't have any other question to ask you. I'll take your questions as soon as you're done. All of you register for the master class for 4 days. That is a very informative one. UG, PG, everybody. And you have an opportunity to make a presentation of a case. We select the scholars for the American College in that. So don't miss out on that session, 14 to 17. And there are limited seats, so register. I think Sukriti will make that announcement about when that form is coming out. You can register. Don't miss out.
A lot of response came on the YouTube. Everybody's saying yes, it was awesome course. We really enjoyed. Maybe feedback, these responses are very good.
And actually, they can switch on their camera.
In here, all the participants can switch on the camera so that we can take a picture.
Please switch on your cameras, all of you. We can take your pictures.
Everybody, please switch on your camera so that we can take a picture with all of you. Everybody.
Dr. Vivek, you could join too. If he wants it, because he has an official responsibility.
Wait.
No, I have to control that now. Camera use कर लेते हैं ना, then you can get both Vinay and you both. Now you can just focus on this.
Please switch on your cameras, all of you. Kadi Beti, Tarushi, Isha, Swarna, Dahlia, Saad Jamal, Raj Seshu, Sneha, Adhesh, Jaish, Abdesh, Jaisukh, Abhinav Ranjan, Soumit Subhash, Tanya, Ramkumar, Malavika, Mark, Anup Krishnan. Please switch on your cameras. Tarushi.
I can see that, Saad, you can't switch on your camera, but that's okay. Don't worry. You mentioned the problem. Subcuticular, those who have done can show it. Dr. Vivek, you said a couple of questions. Okay. They are all visible now.
What question do we not get? Which suture for tendon?
There's a question, which suture for tendon? Dr. Vivek can speak that loudly.
Yeah, the question is, which suture is used for tendon repair?
We use any monofilament, preferably Proline, which is non-absorbable. You can even use PDS. Like I told you when you're answering that question, the suture should be suitable to that healing of the tissue. It should be able to provide that support. But most of us use non-absorbable suture for tendons. So I would prefer to use the Proline. Next question.
There is a question from Dr. Harsh Agrawal. Sir, how to take surgeon's knot with the dart method?
The dart method, surgeon's knot, I taught you. You will start with the index finger throw, take 2 throws, and if there is a shortened towards you and you want to put surgeon's knot, take 2 with the dart. Same, but just the same. But whichever throw you're using, take 2 throws through one loop. So that will take care of it.
Which questions only, sir?
There are other questions you can always post in the group. We'll try to answer as well as we can. But importantly, I hope you enjoyed it as much as I enjoyed getting it to all of you. It's been a long day, but you did well. And let me tell you, a lot of you were brilliant. I was quite amazed at the skills that you have at this stage, which is only going to make you even better in life. So I do encourage you all to take up surgery in your career. It's a brilliant field, and it needs very bright people, and I can see that all of you are bright. So do make an attempt to take up any surgical field which has got a future, any surgical field. It's not just surgery, it's surgery, orthopedics, gynecology, ENT, whatever. And I must, before I conclude, must thank the assistance I got from Dr. Sukriti, who's my registrar, my student, my undergraduate, postgraduate student, and now a registrar with me. You get in touch with her more frequently than I don't get in touch with you. You got to hear about the workshop, etc. So that's number one. And importantly, we got a huge amount of support. And in fact, the entire material is by J&J, the Johnson & Johnson Ethicon Group. And we have Dr. Vivek. If the camera can go to him. Once again, I would request you all to give a round of applause for him, wherever you are. And Mr. Vinay for being extraordinary in supporting. You know, the challenge of doing it in COVID times, but I don't see any challenge with the way I saw you working. You could do everything on the gloves, and you realize it's more about learning the technique. If you can do it on the glove, you can do it on the, on the tissue very easily. Some of you were brilliant, and I must congratulate a lot of you. We've noted down about 20 of you, and definitely 15 would be those based on their performance in the conference that we are having from 14th to 17th of August, we'll be able to pick up scholars for the American College of Surgeons. They'll be sponsored for becoming resident members of the American College of Surgeons. And as governor and president of the college, it's my responsibility and shall I use the word authority or privilege to be able to do it. So thank you all very much for sitting through. And once again, God bless you all. Stay safe, take care, and do practice what you learned today. Don't practice granny knot. I'm repeating. I don't know why were you so fussy about learning. Granny knot. I showed you why you should not learn it. Don't just practice it today. You should do it some other time when you will be able to differentiate between where it can help. You saw that it was useful in vascular work when I was trying to place a suture in the deep so that it can go down. Now I think the camera is switched off. Mine too. I don't know why. So any questions at the end? Anybody? You can unmute and speak. I'll ask the organizers to take over, and I must compliment them for putting it together. Having at least an idea of what skills are all about is very, very important for undergraduate students to start at this stage. Any questions from anyone? If there are none, then I think we can close it. Is any of the organizers there?
Yes, sir.
So you're okay?
On behalf of entire, yes, sir.
Please, carry.
On behalf of entire GSN team, I, Udit Kathuria, the Academy Director, would like to thank you, Professor Chintamani, sir, for this amazing interactive workshop. Thank you, sir, for teaching us different kinds of sutures and knots, such as simple suture, surgeon knots, a burden knot, continuous suture, and a lot more. I would also like to extend a heartfelt thank you to Sukriti ma'am for her constant support in planning and execution of the workshop. And a special thanks to the working group of GSN and Akatya Vidushi, the president and founder of the GSN. This workshop is endorsed by American College of Surgeons India chapter and sponsored by Johnson & Johnson. This hands-on experience has boosted our confidence so much. I am sure it has been an informative and enriching couple of hours for all of you. Today, all of us have realized that suturing is truly an art form. Thank you everybody for joining us, and don't forget to attach at least 3 pictures of your sutures and knots in the feedback form to receive your certificates. And a quick reminder for all of you who are not members of GSN yet. Enroll now and be part of such amazing workshops and webinar in the future. Thank you again, everybody.
Thank you, Udit. I hope you also did some knotting.
Yes, sir.
Great. So don't just get involved into arranging. Do something. It's for you too. You're all the same. You're all batchmates, all same age group. So all of you must learn. I often find that we get too lost into organizing rather than learning. So I'm glad you organized it, but importantly, put it together, use it, and practice. All right?
Yes, sir.
Thank you very much. With that, we can close it. Have a great time ahead. Be careful. Stay safe. Thank you all very much. Bye-bye. Good night. I think it's evening still. I'm not aware of the time outside. So what time is it? So it's 6:30. So have a great evening. Relax now. And I once again thank Udit and his team for putting it together and making it special for all of you. Have a great day. God bless you. Bye-bye. Thank you.